see us in operation, understand how some of our governance is working, see how we participate in discussions and make decisions, but the public are not able to ask any questions unless they do so in advance, and we haven't had any questions in advance. We have a number of apologies today. So we've got Dean Andrews, who's the Chief Operating Officer for Bournemouth University, David Freeman, who's the Chief Commissioning Officer, but we have got Kate Calvert here in the room who's deputising for him. Stephen Slough, who's the Chief Digital Information Officer. I don't think we've got anybody deputising for Stephen. And John Sloper, who's here for the BCS sector and will be with us in the afternoon. So he's here for the session. 11, thank you. So my understanding is that Matthew Bryant, who's Dorset Healthcare and Dorset County Hospital Chief Executive, and Rachel Pearce, who's South West England NHS, will be joining us later. So we'll welcome them when they arrive. I also wanted to say we've got a number of people on the screen who are actually members. So good morning, everyone. And use your protocol if you want to come in, just please put your virtual hands up and I'll bring you in. And then I also wanted to say a really big welcome to Councillor Nick Island. Nick, this is your first formal meeting, having been appointed as the member for Dorset Council. So welcome. I know you were newly elected in May of this year. I think we saw you at the last meeting, which was held in Bournemouth, and apologies for not recognising you then and introducing you, but welcome now that you're formally a member here. And then we also have two members of the public that have joined us. Can I ask you to just introduce yourselves?
Sure. I'm Dr. Vladimir Ljubicic. I work for C2AI, which is British AI company looking at risk stratification need assessment.
Thank you very much.
I'm Neil Manson. I work for Roche. I work on collaborative projects across the Southwest in oncology, neurology and ophthalmology.
Thank you, and welcome to both of you. Right, so can I just check, are there any declarations of interest before we proceed? Okay, so in that case, what I'd like to do is to take us to the minutes of the last meeting. Okay, so minutes of the last meeting, sorry, having problems with my system here. So can I just turn the pages and take us through? If there are any corrections or amendments, advise them, please let me know. So starting on page 2, 3, 4, 5, 6, 7, 8, and 9. So we'll take those as an accurate record of the last meeting. We also have the action log. All of those actions are complete. So that then moves us to the board story. And I think we've got Mark Smith here as the principal lead who's going to take us through the board story. So welcome, Mark.
Thank you.
Mark, do you want to introduce and tell us what the board story is about? So, because I'm not sure if everybody's aware.
Yeah, thank you. So we've made a short video. In Dorset, we are responsible for providing healthcare to 3 different elements of migrant healthcare at the moment. So in Bournemouth, we have some hotels with asylum seekers. You've got Baby Stockholm Barge on Portland with asylum seekers, and the army camp at Chickerell with Afghan entitled persons, they're referred to by the MOD, people who have been working with the British government in some form or other, and moved to the UK and are entitled to residency when they get here. The video explains more about that, and there's some interviews with some different people, and I'm here just to take any questions and discussion after.
Thank you very much. Can everybody hear? Can I just check physically online? Yeah, great.
Services are provided.
Start there.
We have a duty as NHS Dorset to ensure that healthcare services are provided equitably for the migrants arriving in our county. There's three distinct areas we've got in Dorset at the moment. So we've got there's asylum seeker hotels in Bournemouth, which have been around now since 2020, 2021, I think, so a few years. There's 500 odd people across those hotels in Bournemouth at the moment. We've got the Bibby Stockholm Barge, which again is asylum seekers. It's floating accommodation, more important port, about 400 residents of that at the moment. And lastly, we've got the Afghan resettlement camp in Chickerell in Weymouth.
So to explain what happens here at Chickerell Camp in Weymouth, this is the Army providing temporary accommodation for entitled persons from Afghanistan who are waiting for permanent accommodation elsewhere in the United Kingdom. There's capacity for around 250 EPs here, and at the moment we have 210 on site. An entitled person is someone who's been relocated from Afghanistan to the United Kingdom under certain government schemes, because if these people were to stay in Afghanistan, their lives would be in danger because of the help they gave the United Kingdom during our operations in that country. So the way the Army is involved in helping the entitled persons at Chickerell Camp is in a facilitator capacity. We're here to get them access to the healthcare they need by providing things such as transport, logistics. So we don't provide direct medical assistance except in emergencies. We help them get to the healthcare they need. The health provisions that the entitled persons can access while they're at Chickerell Camp include a GP service. So we have a doctor who comes to the camp 5 days a week and runs a surgery here. We also have a prescription service. So when the EPs are provided with prescriptions, then we run a service to the pharmacy twice a day so we can collect them for them. We also have a health visitor and a nurse and a midwife who come onto camp whenever necessary. There are a few challenges, one of which is when the EPs come to this country, sometimes they have undiagnosed health conditions, and when they're examined for the first time here, these appear, and then we have to treat them quite quickly. Another difficulty is that there are cultural differences between what men and women can do in their culture and what they can do in ours. But we have a fantastic team of linguists who are on site 24/7, and they help us bridge that gap.
My name is Dr. Neiman. I'm the senior partner GP at South Coast Medical Group, which is a network consists of 5 practices situated in Bournemouth, Boscombe area. And we were asked to look after the 2 groups in the settlement of immigration. The first one was the Afghani refugees, which are situated at Weymouth, Chickerell, where we run daily clinics looking after their needs and introducing them into the NHS environment. We also run immunization clinics and smear clinics at that site. The second group is the asylum seekers, and they are located in different hotels in Bournemouth and in the Barge in Portland. We do clinics also on daily basis where we look after their physical, mental needs, as well as any other issues arise while they're living in the UK.
So to qualify to attend this clinic, they have to be asylum seekers that are living presently in this area. So in the area of Bournemouth and Boscombe and the greater sort of Bournemouth area. Usually they are residents in the hotels of the area, so the hotels that are nearby, and they're on the list of the Home Office officially as a asylum seeker seeking application, but they're also our patients in respect of that. So they're all on our patient list, but they are specifically titled as asylum seekers because they don't have a current legal status in the United Kingdom.
So as well as the physical health needs, we have had to make sure that the mental health and wellbeing needs of the individuals are being met as well. Like I said a moment ago, some of these guys have come through various different routes to arrive at where they are today, and there's a lot of trauma in people's past. So what we've done is make sure that the pathways and the relationships and the connections between local mental health services exist and they're functioning, which is working well. Also for the barge specifically, we're working with NHS Talking Therapies team to provide and develop some onboard group sessions for people. We've got to follow the clinical guidance as well, and it's to engage in sort of trauma therapy, for example, you have to have the right environment, the person has to be in the right place to do so. And because these guys, their future is uncertain, they don't know where they're going to arrive next after the barge, it's not appropriate to engage in full sort of trauma therapy at that point. But what we have done is develop a group and make sure that there's a mental health practitioner on board for a couple of days a week that will see people individually if their risk levels rise or if there's a safeguarding issue.
So it's not always your everyday GP presentation. They can be quite complex. Apart from mental health, you can see a lot of muscular pains, a lot of post-traumatic pains that they've gotten from injuries that they've had in wherever they were before. So, and then you can see some infectious disease kind of things like scabies and rashes and things like that because they're living in conditions where they're quite close to each other. So that's also quite prevalent. They do appreciate what we do for them, which is very, very important as well, to get that job satisfaction. You know, it's quite good to see them smile when they leave. They're very thankful. They shake your hand multiple times. They say, thank you so much. So it's quite rewarding to see that.
My name is Mohammed Ramesh Azizi, and I'm staying here in Children Camp, training camp. Yeah, with my family, and there's a lot of families here. Yeah, so the situation of the NHS here is very good, and any times we have any problems with because of need to the doctors, and so the doctor in the camp, so they are help us, and they are good guys, you know, they are help us. Yeah, all of the things. Yeah, when there's small things, you know, like a pain and something like so the child have a fever, cough, or something like that. So first of all, we can visit the doctor from the camp. And if it's important things, you know, like emergency things, yeah, we're gonna call 999 or 111. Army guys are their job is doing so good, you know, and also the MERS team and the interpreter teams. Also, all the guys here they are so helpful people, you know. They are brilliant, you know. They are good. Yeah, they are most beautiful people, you know. Friendly with us, you know, so yeah, any kind of help we need, they are doing for us.
I find it terrifically rewarding because these EPs in Afghanistan, they offered Britain their lives, and all we're doing is offering them a place to live. So it's quite a good deal. And when you see the children running around smiling and in the uniform for their first day of school, it's very heartwarming.
Mark, did you want to say anything else?
I think the thing that I've wanted, so I've been involved in the three different aspects for the past 6 months or so. I wasn't involved in the planning stage at the beginning, but what I've observed, I think, is that it's been quite complex to implement the different healthcare aspects, but it's been a really good example of multi-agency working. At the Chickerell site, for example, you've got the MOD, Health, Dorset Council, Children's Services, Education, MERS, who provide the welfare up there, and to make sure things function, you need to have really good communication. You need to have some good, strong relationships by everyone working in that environment. The same for the barge as well. There's multiple agencies delivering that provision on board. So it's been challenging. And I've been sort of, my role, although it's been one of commissioning, I found it became quite operational at times, because I was asked to sort of get involved and sort of work through any teething problems and operational issues, which I found quite rewarding. It's also been a difficult balance to strike, I suppose, because as everyone knows, the migrant situations are always in the media. It's quite contentious, especially with local populations. Protests both for and against the barge have happened. So it's been a difficult one to sort of manage, to make sure that we are doing the right thing for the residents, but also considering the local population as well.
Thank you. And I think what came over on the video was it provides lots of rewards as well, isn't it, for the people that are working with the migrants right across those multi-agency teams, and being described as the most beautiful people. I mean, what could be better than that? So, are you happy to take questions and observations from board members?
Of course, yeah.
Yeah. So Paul first.
Well, I was just going to, and apologies for being late, Chair. I was just going to say that actually the teams, both the commissioning teams and the teams that have designed and delivered the service, have done this under the sort of pressure, the political pressure that understandably we've seen in the news and has been reflected in the way that we've had to work and operate, and often with quite conflicted and challenging personal positions in this, and they've done it really well. And I think to get to the point of delivery where we're at the moment, where, and I think Mark said it well, that these people are getting the health care that they need, but without us having to then compromise healthcare for other people in order to do it, I think is a real testament to what's been achieved. There's still more that we could do, and there is still more resource, particularly the discrepancies between, places that have been high profile like the barge and those that have been less so, like the hotels in the Bournemouth area. So there's still lots more that we can do, but I think given the resource that we've got and the pressure and scrutiny we've been under, I think the team have done a really good job to be able to do this. And Matt and I have been in enough conversations to try and manage some of that political pressure, but it's been incessant at times. And I think talking about the population that have come, there's been some really good positive stories. I mean, I don't know whether you saw in the news that one of the barge residents decided to enter one of the toughest off-road running races in the area in a pair of old rubbishy trainers, and came, I think it was second or third, and defeated most of the professional cross runners. And there are stories there that actually have actually helped them embed within the community and given them a positive slant despite some of the the local concerns for when they first arrived. So I think they've helped themselves. The multidisciplinary approach has really helped it, and I think that has sort of set a really good foundation for the health service to be delivered in a way that has just been described.
Thank you. It's useful to get that input. Matt, I know you want to come in as well.
Thanks, Jenny, and thanks, Paul, for that. I guess for me, there's something about making sure we've got the language and the terminology right, and it all slightly rankles when I hear either people talking about the Home Office, talking about service users on the barge, and you heard our military colleagues talking about EPs, in shorthand for entitled persons. And we're talking about migration, but we're not. We're talking about two very different cohorts here, aren't we? Chickerell Camp is under the ARAP scheme, the Afghan Relocation Scheme, which is a legal route. These individuals and their families have supported the British military and British government overseas, and have indefinite right to stay in this country and access to full resources that we can offer them. The complication is that they arrive larger families on average than we have here in the UK, and that's what's taking some time in order for them to move from the camp into their settled accommodation. When the scheme was set up, I think we had 2 weeks' notice of this happening, and the first plane of families arriving, we were told 6 weeks, would be the sort of turnaround mark, and that's important because actually our role as statutory function in terms of education is different depending on the length of time they're with us. As it now transpires, they're with us for a lot longer. and therefore you heard the young man from the army camp talking about their first days at school. So I'm incredibly grateful to our local schools who stepped in and stepped up for that process. It isn't easy for them. There are still language barriers and there are still issues around integration there, but the local community has been incredibly supportive of both of those schemes from my perspective. I can't refer to the hotels, but you didn't want to. Whereas the Debbie Stockholm, men only. It's very clear that was part of the cohort around safeguarding that is men only, and they are asylum seekers. They have a legal right to be here and are seeking asylum and waiting for that determination. I think we should just make that really clear. As I say, the community support has been really good for those, despite some tensions that Paul referred to. And I think we need to continue to work in that multidisciplinary approach to provide service to. We are meeting with the military this week to try and get the camp designated differently. Because at the moment, the one thing that Dorset Council doesn't get is any resources. So I understand. I think the health service function is being supported and funded through the national scheme. Because it's designated as a short-term site, we don't get any funding. The reality is it isn't a short-term site. We've got some families who've been there up to 6 months now, are waiting their forever home. We have a legal obligation, a statutory obligation to provide education and support to those families, which we'll continue to do. But clearly, in terms of sustainable long-term, it would be helpful if we sought funding for that. So we're pushing that door. But I say both schemes have been operated, I think, incredibly well despite the challenges that have been presented.
Right. It's really helpful to get some more insight into all of this, isn't there? So I'm sure you can do this anyway, but if there's anything we as a board can do to support those interventions and the requests that you're making, then please let us know. Okay, sorry, Paul.
Yeah, I mean, it sounds really good. It's really positive, and I hope my patient survey is as positive as the feedback you're getting there. What I wondered was what's not going so well. Are there any gaps or anything that, as a board, we should be aware of where there might be an opportunity that we could offer more support?
I think resource in general for the primary care provision is stretched. South Coast Medical provide across all three aspects. Also, across all three sites, the residents are entitled and have access to the normal healthcare that anyone else would as well. The multi-agency aspect is working well, although communication in pockets is still an issue. I think in general,
Whoever just joined, turned your microphone.
Apologies.
Also, you haven't done that before.
Resourcing is stretched and spread thinly, I think, in essence.
So I didn't hear that last bit.
So the resource that we have is stretched thinly, I think. And originally in the planning phase, obviously because the barge and Chickwell were both focused in Weymouth, Weymouth the Port and PCM were approached and they were unable to support those elements, hence why South Coast supporting that.
So at the moment, that resource is coming out of one GP practice, one PCN.
So they're contracted, to provide that across all of the other bits. I suppose the other, for the barge especially, mental health and wellbeing often gets raised as an issue. Like I said in the video, it's difficult to engage in sort of full trauma therapy in that environment through justifiable clinical reasons. To give you an example, the last time I visited the barge, which was a couple of months ago, there were 29 different languages being spoken on the barge. So to deliver a talking therapy style group, as you can imagine, is difficult. 50% of the main language is Arabic. So we're doing it in stages. So and the talking therapies team are going to use translators and deliver an Arabic session first of all, and then sort of test it. So a bit of a test and learn approach. There's various other sites across the country which we're learning from as well. So we're hooked into sort of the national and regional conversations on that.
Matt?
Things that are not going well, talk about more challenges rather than not going well. The kind of cultural aspects are not actually between the groups on the ground here and the migrants or those entitled people that have come to stay with us, actually between the organisations that are providing support. So you've heard some of the different languages there between the military has a Bible of acronyms, which I think has got about 800 different 3 or 4 letter acronyms. You will know that health colleagues have their own set of Bible of acronyms and local government has its own set. So in terms of that piece, that kind of language piece, but also that cultural piece. So our military colleagues in the first instance explaining that the circumstances these families had come from, that this set of very basic barracks in Chickerell was an upgrade, wasn't acceptable to members of my team. The kind of aspects of health and safety that the military said, well, you should see the camps they've come from, and say, well, this is safe. No, because this is the legislative framework we work in. It doesn't matter what they've come from. We need to make sure that we're safe here. So a little bit of work around there about making sure that actually organisations going, actually, when they come, doesn't matter where people have come from, what they're brought to here has to be safe and secure and in line with our legislative requirements. So there's been some learning curves for colleagues as we've got through that, moving at pace. And that, I guess, is the lesson we would take forward to any, if a future scheme set up, would be early conversation, making sure we've got a common language, and therefore we've got a common understanding of how we're going to provide services to whoever it is we're supporting.
Very important, and can I thank you and your teams for doing that, because it is about treating people as humans, isn't it? And the point you made as well about calling people EPs, so thank you very much for that. Patricia and then Rhiannon.
So I was going to comment on that, Matt, because, well, first of all, I just want to thank the teams that have been involved, because we didn't have a lot of notice and this has been really, really challenging. Paul and Matt have had very difficult conversations with central government, and a huge thank you to Mufid and his colleagues for stepping in to provide a service that has been absolutely essential. There are some thoughts for me about the language that we all use, referring to people as refugees, asylum seekers, labels rather than seeing them as human beings. That actually many have been through an incredibly traumatic life and journey to get here, and there is some thought in my mind about whether we need to invest a bit of time and resource in all of our teams that are involved to make sure that we absolutely understand the journey that those individuals have taken, and a more deeper understanding of what they need in order to feel safe here, because it's not just about the environment, it's also about the kindness and compassion that they're shown, as well as the clinical treatment that Mufid and his team and Matthew's team at Dorset Healthcare will be providing, because cultural competence is really important in this space. Otherwise, there's no point in us providing PTSD support if people do not feel safe in the environment that they currently find themselves in, with all the uncertainty that goes with that in terms of when or possibly not they're going to receive indefinite stay and be able to make life. So that's my thought about whether we want to engage in some of that, and if we do, then our chief people officers, I think, will be more than happy.
Patricia, is that discussion you want to take up outside of the board, probably with the CPOs? And the thought that was going through my mind when you talked about that was also about what support are we giving the staff who are supporting, because there might be a transfer of trauma, for example. So we'll leave that in your hands, Rhiannon.
Yeah, thanks, and really helpful to hear the context, both positive and the challenges. What was left in my mind from Matt's update was, is there any sense of what that timeline is for those people entitled to settle, and how, specifically around housing? Is there any indication of when they may be able to have their homes and settle?
So the reality of the scheme is that for those smaller family units are moving on more quickly. It's the larger family units, sometimes up to 14, where you can imagine that there isn't the same kind of housing. They're being offered housing potentially in Scotland or Northern Ireland, which they can see them going, well, is that where I want to go and be placed? So it is that's the problem. So the MOD, when they launched this scheme, Lazarite, middle of last year, actually took over quite a lot of MOD properties, but they needed work doing to them, so that's part of it. But most of those properties are fairly traditional. There might be some 5-bedroom properties, but family of 14 now. Again, that comes from the cultural challenge. Many of those families will say a house with 5 bedrooms, 14, that's fine. We wouldn't allow that. So it's taking time to secure those properties. I think the longest family we've got on campus has been with us 6 months. Again, is a family unit of 14. So that's not in our hands. That's in the MOD's hands, securing that housing.
And not necessarily Dorset. So
no, very, very few in Dorset. We have some Afghan families under a different Arab scheme, and we've had some support from government to purchase properties, and a number of those families are actually supporting interpretation and work at the camp, as well as some of our Syrian families who are settled. They've also in terms of that. But no, many of them not in Dorset at all. And same with the cohort on the Bibby Stockholm. Their status when it's determined off the barge, and it's not in Dorset.
Gillian, did you want to say anything about the hotels? Because I think no, that's fine. All right, so Mark, can I thank you? And if you could pass our thanks also back to your team and the people involved. And if we can ask Matt and Paul to do the same. And of course, we had a couple of actions that came up from that to take forward. So thank you very much.
Thank you.
You're welcome to stay if you want to, but you don't have to.
No, I'll leave. Thank you very much.
Don't need to say like that.
I have another meeting. I would.
I was teasing. So. Okay, so that takes us onto the board assurance framework. Neil, I've seen you on screen, and this is really going to be looking at the strategic risk for the ICB. And the amendments that you've asked us to look at, which includes looking at the risk appetite statement for domain 2. You're on mute.
Thank you. Thank you for all the work that everyone has put into this, both at non-exec level and exec level, as we iterate and improve the document. I'm sure the people have read the paper. As you say, the risks have been reviewed, realigned, taking into account the comments and the feedback and the suggestions. There's 2 new risks, risks 4 and risk 7, which I've identified and incorporated into the framework. And then secondly, the second issue really is to review the risk appetite statements in relation to whether domain 2 regulatory is set at the appropriate level. That was an area where we had quite a lot of conversation. Shortly, I'm going to come on and ask the owners of the specific risks, the 2 new ones and one where we are still out of tolerance, to speak in a little bit more detail to the board about what they've done, how they've done it and why they've done it. So you get that little bit more detail around it. Obviously, I think it's important, we whiz through the cover pages and the issues there, but the governance and compliance obligations for the BAF are really important. Obviously, if we didn't have a good, robust board assurance framework addressing our strategic risk, we're going to really increase the risk of poor governance, ineffective risk management, and just not getting where we want to do and losing public trust. And I think, the sort of the history of many sectors and many parts of health sectors over the last decades is public trust is a critical thing. So I think the board assurance framework, whilst I won't pretend to think it's the most exciting part of what we do and the most exciting part of our journey to improve the lives of the people of Dorset, but it is fundamental, and it has been a very useful progress, I think, not just producing the document, but in helping the exec and others think about what we do and why we do it and where our real strategic risks are. And it also helps us lift our heads up from the day-to-day emergencies and the latest challenge and the latest target from NHS England, which are rarely strategic. And obviously, robustly managing these risks across each of our directorates and across the whole organisation underpins the delivery of our fundamental purpose. So the other area which I think is important when we talk about our fundamental progress and when we get the strategic risks right, and if we really do manage these risks, and by manage them, I don't just mean put in the appropriate mitigating things, think we've done the document, but we actually change what we do and how we do it. It will underpin the system working opportunities, which are absolutely the core of what we do. I was in Dorset Council yesterday with Matt's colleagues talking about how we align our transformation work, and we realised very quickly that they have one of the pillars, their pillars exactly overlies our pillars, but we're not working together properly. And I think I use that as an example of taking the board assurance framework and the document back to what does it mean in real life and how does it change our behaviours and what we do. So specifically of the update to this document, at May, there were 5 strategic risks identified, aligned to the strategic objectives as we've outlined in 2.1 in the document. We reviewed the risks, realigned and added 2 new risks, risks 4 and risk 7, which have been identified and incorporated into the framework. Risk 4 lies with Paul Johnson and risk 7 with Dawn Harvey. So I'll be asking them to outline to the board what we've done there and why we've done it. Additionally, and just a sort of a little preview of what's coming up in future board meetings with further episodes of the board assurance framework, we've identified a new risk on social mobility, the need for strategic commissioning approach and contracts to be outcome based. that really is sort of, obviously you'll appreciate there's quite a lot in there, quite a lot to be unpacked, and that will be coming in future versions of the board assurance framework. That really sits with David Freeman, who's obviously not here last week or this week. So just to sort of preview that one. As I say, there are 2 risks that are still outside of tolerance. One's health inequalities, again, Paul Johnson's, and then risk 5, enhancing productivity and value for money, which sits with Rob and Dean, and Rob may well want to speak to that today. In terms of risk domains, at the previous Strategic Objectives Committee, we noted that the risk appetite statement for regulatory set at minimal did not perhaps appear to align with all the other areas. So that's an area I think it would be helpful for the board to look at. So in conclusion, we're going to ask the board to note and approve the board assurance framework, the updates, the contents, and review that risk appetite statement. But I think it's probably most helpful if I hand over to the owners of the specific new risks and those out of tolerance. So can I ask Paul to speak to his risk 4? Thank you.
Thanks, Neil. So when we went through the risks, obviously reducing health inequalities is one of the 4 key purposes of integrated care systems, and we hadn't acknowledged specifically our risk against delivering against that. And so this risk is really to articulate that. And although the causes of inequalities are vast, what we've tried to do is say, what is the bit that we as a system lead and an NHS organisation, where do we have the greatest influence and impact and responsibility? And that's why it's honed down onto how we design, commission and deliver our services in a way that is historically prolonged or exacerbated health inequalities, and therefore our risk is that we don't alter the way we do that in such a way that reduces the health inequalities. So it's got a very low tolerance and a very low target risk score, purely because actually not reducing our health inequalities is not something that we felt we would consider acceptable for us as an organisation. And so therefore we felt that this was a low, we would take a low risk approach to this. And then it's outside of that because we're not there at the moment. We cannot describe confident plans that says we are going to reduce our health inequalities. But what we then try to talk about is, first of all, what are the assurance processes that we've got in place? What are some of the controls? And those 4 key mitigations that are coming on board that will then start to describe some tangible plans that will hopefully give us, well, the intent will they will give us confidence as an organisation and as a board that we have the right systems in place to turn the tide and to change the trajectory that we're on around inequalities. And the main reporting of that through for a governance process and assurance process will be through the POC committee.
Do you want to say what the POC committee is?
Prevention, Equity and Outcomes Committee. I've realised I've said committee through POC.
So should we have a discussion around that before we move on to the next one, Neil?
Thank you.
So thoughts, comments, observations? I guess I've got one, Paul, which is we know that quite a few determinants around health inequalities are actually not health issues, are they? So I'm just wondering, is the risk tolerance and sorry, the management of this, looking at how the ICB utilises levers, what is the way to get into this? Because we're not necessarily going to have the response to the health inequality.
So I think there's 2 lenses through this. There's the lens that looks specifically at how are we mitigating this articulated risk, and that is very much around what are we doing around our commission services and our designs and the way we're approaching a whole pathway approach and using our intelligence such as DICE and population health management. So those internal things that we have. But that is not the totality of the work that we're doing around health inequalities. And so when those plans come through, there will be a proportion that are focused on managing the elements of health inequalities that are articulated within this risk. there will also be some work which is much more about partnership working and the work that we can do jointly around mitigating some of those wider determinants. So it'll be both and, but just not necessarily articulated.
What's coming on that later? Okay,
Yeah.
and then I'll go to Rhiannon.
Because I think when Paul's right, there's probably 2.5 strands, I think, which is what we need to do in pathway design, which is where we can influence by 10 or 15%. There's the wider determinant work we need to do, and that's through the ICP. But I think the bit that we need to grapple with as health organisations is being absolutely clear that we are maximising our opportunities in that social value space, and that gets into our role around the wider determinant. And I think we need to do more work in that space. We're absolutely clear. Our people plan for organisations is maximising our opportunity to increase social wealth, that we are really seriously thinking about where the opportunities to use our estate for things other than health service provision, and that we are doing everything we can in terms of that the green agenda around the environment, and making sure that we are contributing as much as we can to the healthy green spaces agenda. And I think we've probably got a bit of work to do through the health and equality team to make sure we are maximising those opportunities.
Helpful, and I guess Dawn will pick up on if interest with that. So I've got Rhiannon and then John. John, in fact, your hand's gone down. Have you changed your mind?
It was, I was going to make a point very similar to Patricia's, so it was a build.
All right, so Rhiannon.
Yeah, thanks, Paul. It was just specifically around the gaps that have been identified, and a number of key controls that are just, I suppose, helpful to just understand whether you have confidence that they are, the timeline for addressing those gaps is as it would need to be, then timely and impactful in the way that you would hope to close those gaps.
So the timeline, just so the helpful for the timeline is that we will have so we've developed and we've signed off, and the committees have seen the strategic approach around health inequalities. What will then come through, and it'll come through the health inequalities group in September, and then to the prevention and equities and outcome committee in October, will be those plans. Now, at the moment, I haven't seen enough detail within those plans to know the level of confidence, but I think that would be my ask within that committee, that's where we apply that scrutiny. Do those plans, are those plans sufficient enough to give us the confidence we need to mitigate them? So I would say I don't know at the moment, but please let's make sure we do address that properly, and then through a chair's report, make sure that the board is aware in that October-November cycle.
Thank you.
Okay, Neil, do you want to move us on then?
Thank you. I'm going to look at Dawn and ask if she could brief the board on. Thank you, Dawn, on the new risk that's been put in.
Thanks, Neil. Morning, everyone. The work that we've been doing on the board assurance framework has been incredibly helpful to move on and improve on our thinking. So why is this a new risk here today? We've got a people risk, a people and culture risk, of which widening participation and the ability, the risk around us adding social and economic value is a subset. However, the scrutiny that we've been doing in this space has brought us to the conclusion that one of the core purposes of our ICB is about helping to deliver the broader social and economic development. And workforce is such a key part of that to lift this out and give it its own focus as its own board assurance framework risk is felt like the right thing to do, especially when we dug into some of the really big challenges around being able to deliver this. So you'll notice the risk is within tolerance. It's not, and our target risk score is 8. So there's a way to go on the target risk score. There's the focus and the scrutiny that bringing this out as a BAF risk will give is so important, given the constrained financial context in which we're working as a system. That really does limit, or potentially could limit, our ability to move far enough, fast enough with this agenda. So, for example, around funding for how we fund apprenticeships, what a real living wage actually looks like for Dorset, and can we make the investment case to do that? What we know through our data is that the workforce that we grow across Dorset, growing our own, is vital to our productivity, because we get better retention, we get better retention rates, we get better staff engagement rates. So there's a productivity argument here. So my aspiration for having this risk on here is that we get the right focus and scrutiny coming through the People Engagement and Culture Committee that will help us to drive forward some of these mitigations within our constrained context. Happy to hear from others.
Hey, Dan.
I want to say thanks for this. Feels like the culmination of quite a long conversation about what's the role of the ICB and where does people, and this really helps focus the mind. And I think it's a really well written and crafted, and so really focuses on that strategic risk, which is where the BAF kind of can add the value that you introduced. Really welcome it on here. Thank you. The other bit was that kind of I thought as I read it is, are we talking about the NHS element of the system? Or are we talking about broader system workforce? And in a way, you can lose some of the mitigations by getting away by being a bit generic. But it just really made me think about local authority partners, the voluntary sector, and that workforce element. I think it's right that we focused it on the NHS workforce, but I just wanted to pose a question about how wide the system is in this risk.
Okay, shall I take a couple, because I've got Cecilia and Matt as well, and then do you want to come back to Cecilia?
Hello. Yes, I mean it's great to see this piece of work. For me, you know, there's a lot in here that some of which is already happening in other places. We've got the Dorset Skills Board, we've got the Careers Service, we've got lots of working already across those places. So it's just making sure that when we do this piece of work, that we do take into account that which is already happening and basically working, you know, not reinvent wheels. The concept of using the labour market data that we currently have, which I think I've shared with colleagues, again to actually inform some of the work of this group, I think it will be important. And as you've got in there, strengthening relationships and partnerships. I mean, for example, like the current careers service is already working in all of the schools across the county. So those relationships exist. We already have employer sort of relationships in terms for apprenticeships, working with both the colleges. I'm sure you know all of this. I'm just making sure that this is a great piece of work. It needs to be done. How do we just make sure that we don't duplicate stuff that's already happening? The other point I would actually ask about is obviously the labour market data that we have for Dorset shows that the percentage of individuals who are on long-term sick who want to work. And I would have thought that again, getting those individuals back into paid work is something that perhaps should be as part of this programme. Or I don't know whether it sits in this group or where it sits. But, you know, we have, you know, 25,000 people who are on long-term sick, who, you know, a percentage of whom want to work. You know, how do we prioritise working people and getting them back into the workforce? That would be the quickest way of getting more of the workforce that we need for the NHS and for Dorset. We've got 7,000 vacancies this month showing on the jobs boards. So, you know, filling those vacancies is a priority for economic development for our place. Doing that by getting our workforce back to work, I would have thought was one of the priorities that we should take as part of this process. Thank you.
And Matt.
Thanks, Janet. I wasn't going to comment on the local authority links, but I'm sure we can in terms of what we do. The piece for me, in one of my national roles, I'm on the NHS steering company for care leavers, and this is about the care leaver covenant and seeking to get opportunities to endorse it. I don't think it's a direct result, but it might be. Is one of the pathfinders, so we're doing some work around this. I didn't see care leavers in here. It'd be really important to recognise that. Nick and I are corporate parents to around 400 young people. We're really proud of that. We're really proud of them. They don't have often the life opportunities and support that our children directly have, and therefore, as corporate parents, we want to support them into that space. And we've been working with colleagues, and Dawn and some of my colleagues in children's services have been working together. It'd be good to see that reflected in there. In terms of apprentices, we have a target, informal target, of 5% of our workforce in DC doing apprenticeships. We're above that target. That's a slightly what's the right word? Diplomatic word. So, well, we have more than 5% of the workforce doing apprenticeship training, but they're not all apprentices, if that makes sense, because through the levy you can do apprenticeship training courses. What I'd really like is to have 5% of the workforce as actual apprenticeship roles, particularly, not exclusively, because apprentices don't have to be young, but interestingly, I'm looking to bring young people into DC. So I think we're fairly aligned in terms of what the local government wants to do in line with this, and happy to work with it. But we're really good to see care leavers reflected within that, please.
Can you take one more? I've got Matthew that wants to come in. Matthew.
Thank you. So just listening to the discussion this morning on this important topic, I am left with a question in my mind about whether we need to sharpen the focus of this, because it seems to me that in this topic area there are two things that the ICS has a unique role in. And when I say unique, much of that is in partnership. But the two things are under this topic. One is collectively as the NHS, we're almost certainly the biggest employer within Dorset. So we've got that unique role to take a really good look at what we're doing in this area and cover all the ground that's referred to here. But the other role that we've got is for the wide variety of vulnerable groups who find accessing the employment market difficult, which Matt has begun to describe, and Cecilia too. We lead, provide, coordinate, support a range of services that make a difference, and I think that my kind of view would be that we need a sharp focus on those two areas, and therefore we might need to look at this to ask the question, have we got that here, or on the basis of this discussion, could we have another kind of development of this, which would make sure that we are focusing our effort as an integrated care system?
So a few bits of thought there, Dawn. So do you want to come back on them?
Yes, absolutely. And thank you everybody for your support and engagement with this. To Dan's point first, the risk is ICS wide for health and care workforce. So I'm pleased to tell you that the collective working in this space across health partners, social care, local authority, and our voluntary sector is really quite strong and very enthusiastic. The links to the skills that Cecilia picked up on, the links to the skills board, the LEP, the ICP strategy, absolutely. One of the purposes one of my hopes for this risk is that we bring some of those links out of the shadows and are more explicit in the work that can be done in those areas to drive it forward and avoid duplication, and that includes the work with the DWP. There is stuff going on in this space, but there's lots more opportunity there that we can go for. To Matt's point, the Care Leavers Covenant is a big part of what we do, and we need to get that reflected. And to Matthew's point about the sharper focus on vulnerable communities, I'd be really, it would be really good to have a conversation outside of here so that we can fully understand some of those opportunities and how we get it reflected and make sure we're focusing on that. So thank you, everybody.
Okay, so sorry, just before I come to you, Zoe. So Neil, what do you want to do with that? Because that was introducing the new risks, wasn't it? And then we've still got the appetite that you want us to look at. So
yeah, and I think well, it's obviously thank you, Chair, for your time. The other area I think which would be really useful, because we've got one risk that's still a sort of score of 20, and a lot of work's been done on the productivity, the financial performance and value. And if we have got a couple of minutes to Rob to speak to that, I think that would probably be more. I would suggest that would be more useful than looking at the risk statement set a minute, which we could happily take outside of the meeting if people felt it. But obviously, I'll be guided by what the board feel would be most useful.
Okay, so I'll bring Zoe in first, because I know she had her hand up, and then if we go to Rob, and then perhaps we'll take the rest outside of the meeting. So Zoe.
Yeah, no, just very useful risk. I think the only thing I'd like to add in there from the voluntary sector side is that obviously when people have been long-term unemployed and it's getting them back into the workforce, and a lot of that's around confidence and being able to get out there and actually. So I think the other thing is that often a good starting point is that they do voluntary work within organisations, and I think that really helps because they've got that support, but they're not actually being judged on what they do or they don't, and actually looking at all their transferable skills and that sort of thing. And I think, I mean, we do a lot of that, and it really works. And you get, to me, what my findings have been over a number of years is that actually gets them back in a lot quicker. Because it's just dealing and talking to people and saying, you know, everything can be adapted to your needs in a workplace. Don't think that because you can't do this and go straight back into a work situation is not always the best way to do it. So I just would like that sort of in there somewhere.
Yeah.
So thanks, Chair, and thanks, Neil. So I offer to just quickly talk about the financial and productivity risk as well. When we talked about this at the BCP offices, I said at the time, I want to use this now as it's a document that documents things clearly, but actually it's a way of working now that we need to take out into finance and things. And the first thing we realised was when we looked at the strategic risk, we didn't have productivity in it. So Dean and I had a chat about that, and we've included productivity and impact on waiting lists, things like that as well. We've also had a discussion about whether or not productivity on its own is a risk that we should pull out and have a separate one, but we've kept it together just for the time being, and we'll develop that conversation because this will be iterative. Pretty much most of the words on the detail page have changed now, because it was more like an enhanced risk register, and now we try to move it more into the assurance, the controls around more the strategic risks. There is a balance to be had, because in order for us to become financially sustainable and increase our productivity and eat into the waiting list, there is something that you still have to deliver in year as well as the step into the future as well. What I really ask the board, and it can be down outside of this meeting, is look more on the gaps side and then at the mitigating actions. So I said that we were using this as a document that we will now work with and start a work plan, and hopefully you'll see from the mitigating actions that we've started work on the financial strategy, which will obviously get socialised. We started the skeleton outline of that. That's really important that we do that. We've got the infrastructure strategy coming to this board now. Dean's team have been working on the productivity early indicators as well, and that's being tested now at System Recovery Group as well, so we get a good idea, early sights on productivity. And we've got some things teed up with my FD partners as well, that we're going to start having face-to-face meetings to get into some of those difficult things that the system faces in order to enable some of this stuff to happen. So, for example, how do we transact benefits that might be held as system benefits in the ICB, but will be enacted and provided? How are we going to do that sort of thing? Which comes down to financial framework as well. So, quick whistle-stop tour, just to give some assurance that it's a document that will change, it will update. The scores, I'll say now, they're the highest, they're at 20. We have a deficit plan. We are working on a medium-term financial plan and transformation to get us into sustainable balance. Until we can show that and talk it through, prove it, and show all the work streams, I don't expect that score to markedly decrease quickly. So we might be a bit on 20 quite a long time. And Dan, the heavy lifting, I'm sure, will be being done in PPC around some of this stuff as well. Okay.
So, Rob, can you just say what PPC? I'm
sorry. Yes.
Yeah. Time, so I don't want
it's the Productivity and Performance Committee, probably known as the Finance and Performance Committee, but we renamed it to focus on productivity and performance as part of a change of our committee structure to focus on productivity and performance.
And just a reminder as well, because we are meeting in public, if we could try and avoid acronyms to keep people with us, that would be really helpful. So we've been asked to note. No, I'm gonna move on if that's all right. So we've been asked to note and approve the assurance framework and the concept. There's been some discussions here today around certainly around Dawn's movements around change of that side. So Patricia, I don't know if you wanted to maybe
yeah, so I think that, well, thank everybody for their patience, because one thing I've just got us to know is that traditionally CCGs have not had what I would call a board assurance framework. So whilst I'm used to a board assurance framework, having been a senior leader and a provider, some of my ICB colleagues have not. So we've been through a process of education around what a board assurance framework should look like, which is why we've landed here in a fuller document. I think there are some things that we just need to take notice of as we go forward, in that, well, first of all, we've obviously got to make sure that we get the risk in properly that Rob's talking about. I think we need to do some more work on risk 6 that sits underneath helping deliver the broader social and economic development piece. But I also think we need to be a bit clearer now in the board assurance framework what the ICB's role is in managing the health landscape around the 4 purposes of the ICS, is recognising that we cannot do it all. And then we need to be clear on the fact that the rest of the assurance comes through the ICP. And that's not duplicating the work of the ICP, but it's recognising that that committee, the integrated care partnership, is responsible for the wider determinants piece that can't be delivered outside of health, and being clear that we've got the assurance that that work is moving in the right direction, is delivering what we need to in order for the system to deliver its 4 purposes that are set down in the legislation. So we'll do a bit more work on that for next time, and then hopefully what you'll get is the final version of the BAF, and then we'll just keep updating that and using that as the basis with Jenny for setting some of the board agenda. I think we need to think through the conversations we're having at committees, which are very grounded in the operational delivery of our statutory responsibility, and start to think more about how we carve up those agendas in a more sophisticated way that gets us into more of a conversation about how does that work then lead into the strategic direction that we need to follow as a board, and making sure we're getting assurance on both those elements, not just one.
That's really helpful, Patricia, because I picked up 2 things when Neil was introducing. One was, what does this mean in real life? And I think what you're articulating in there is how we get there. And then the second thing was how it aligns to other BAFs. And again, that work should then enable us to do that. And I think it might be helpful when not just when we're planning the agenda, but when the papers come through, that we can see those alignments and those threads. So that's helpful. The second action that we were required to do today, Neil, was really in relation to domain 2. So are you saying you're going to take that outside of today's board and try and sort out the risk appetite on that?
I think that probably, given the pressure on time, and I'm really conscious and grateful for the time that you've given us, Jenny, and the board have given to the BAF already. I think it was just highlighting in the whole group that there's some unease that that's not exactly where it should be. It doesn't feel like, when you read it, how we actually work. And when I read it, I sense that, if you took that to the letter of what it says, the previous sort of organisation wouldn't have even undertaken the CSR, because, unless absolutely will result any regulatory change. It doesn't seem to be how we work, and it doesn't seem to be aligned with our intent. So I think there's quite a lot of conversation, but probably we haven't got the time today. But can I suggest that I sort of bring together those conversations, have the conversations outside, and bring it back to the board? But there may be, I can sense there may be a couple of people with a pressing issue to raise about it right now, which would obviously be super if we've got the time.
I'm going to move us on, if that's okay.
Okay.
If I can leave you to interact. Dan, was that one coming on, was it?
No, I wouldn't make a specific comment, but do you want me to do it outside of the board or
in relation to domain 2 or
no, into relation to risk 6? So are you saying we'll pick those up outside or no?
No, let's do those now. I was talking specifically about domain 2 and the risk appetite, because we're not going to have time to have a proper discussion on that. So
sorry,
okay, risk 6.
I know you're trying to move on, so I'm happy for this to be a comment rather than a question. Patricia just mentioned it in her summary. What I was interested in was the risk is kind of halved, forgive my maths because it's not quite half, but it's gone down to 9. And I couldn't quite see that the actions that we've taken and how they've embedded in terms of system working and behaviours, how they will have halved the risk. And then my build on that is, I can see how those actions might have adapted the likelihood. I don't see how they reduce the impact. And so for when this comes back, it might be just good to get a bit more history and trail on how we think we've gone from 16 to 9. But I suspect that aligns to what Patricia said in her comments about a bit more work to do.
We need to do more work in it because I don't think it is a 9.
Thank you.
Okay. Great. Well, thank you very much for that, Neil.
Thank you, everyone.
Yeah, thank you. So let's move on to Patricia, your Chief Exec report.
Thank you. So, thank you, Chair. I'll take the report as read. I just want to just reinforce a couple of points that I think are really important. And in the key update national ones in the front page, the reason why the new government isn't listed there is because this report was actually written before that, and I did make them hold on to it until Friday morning because I had written a section about the new government, and obviously if we didn't have a new government I'd have to retract that bit. So some really important things in this report, I think. First of all, the operating plan is signed off by the centre, but it still contains a huge amount of risk, particularly around the finances. Rob will talk in more detail when he goes through the finance report that we were off plan slightly in month 2, and so we've been asked, like all systems that are off plan, to provide some additional assurance to NHS England and the regional team. I think our prediction at the moment is that we probably will be back on plan at the end of Q1, but that doesn't take away from the fact that we were off plan on Q2. Our cost improvement programme takes a significant step up in terms of plan delivery at month 6. So we are currently getting assurance from partners that they are ready, able, and their plans will step up at month 6, so that we know we've then got a big chance of delivering on the deficit plan that we've agreed for 24-25. The blood inquiry has been, and not just that actually, there's been a number of media, a lot of media coverage on different quality and safety issues across the NHS in the last few months that have really focused the mind. I think there are some things that we really need to think about around how we get assurance in our system on the learning from those. Important things for me are twofold: listening to patients and their families. When we don't do that, we move the relationship of trust into a place we don't want it to be, and we don't make sure that the experience of those individuals, both clinically and personally, is optimised in the way that it should be. So I think we need to think about how we might get assurance on that as we go forward. Also, the need for a really good, robust clinical governance processes that identify poor clinical practice. And in some areas of the NHS, that's great. In other areas, it's not. And again, we need to think through very carefully how we're going to get assurance in that place to make sure that we are comfortable with the processes that are in place, to make sure that when we identify poor clinical practice, that action is taken either in terms of development or more serious action through medical management. The really important theme, I think, that we've got to think through in terms of the leadership community is the NHS is always going to face challenges, some more significant than others. How do we manage our teams through that so that they do not get compassion fatigue, and then what we see and observe are behaviours that are not helpful and that are not in line with the values that we've set? And I think we need to think through that as a wider NHS very carefully, because there is no extra funding available. The Treasury made that really clear. We're going to head into probably what is a very difficult winter. We have the potential of industrial action from our primary care colleagues. And the BMA meeting with the Secretary of State this week, we do not yet know if a settlement has been reached with our GPs. So there's going to be, with our junior doctors, sorry. So there's going to be a high level of expectation from our new government around delivery, and that is not going to be easy. So we need to think through very carefully how we support our staff through the next 12 months to be seen to deliver, but also supported in terms of their own mental health and wellbeing, so they offer the best care to patients, that they are mindful of the fact that kindness and compassion matter, but we're also supporting them through what will be a very challenging few months. Cybersecurity, an ongoing problem for the NHS. We've had a number of cybersecurity incidents across the NHS and locally. We know that our IT in some places is not where we want it to be, so being clear that we've got good plans around that, good assurance around that, and that when we have incidents we take the right steps very quickly is incredibly important. We are doing very well across the Dorset system in terms of developing a cybersecurity strategy with partners, but we just need to have our eyes on making sure that that is implemented and our systems are as possible to safeguard not just the provision of service, but patient data. As I said, the Secretary of State's two really important meetings this week, one with the BMA to try and curtail further industrial action by our junior doctors, two trying to get to a settlement with GPs that they're comfortable with, and then a further meeting with the National Dental Association to try and land on changes to a dental contract that make it fit for purpose. With the previous government, we've been heavily involved in those conversations, and it's really pleasing to see that the ministers are well known to some of our areas in the southwest, and also that the advisors, the majority of them have come from NHS England, so that conversation of influence should be able to carry on with people that are knowledgeable about the context within which we're all working. I've outlined for you a number of priorities for the system, which are the corporate priorities, that we've agreed with the ICB, and also some of the risks that we're heading into going forward in the next year. I think what is really pleasing to see is that, having spent a long time reading the extremely long Party Manifesto, that it is really good to see that our strategic direction is fully aligned with new government, which means that we're heading in the right place. Thank you. Any questions?
Thanks very much, Patricia. So, any questions, comments, observations?
A couple, really. It is going to be challenging, but I think it's important not to lose sight of some real glimmers in here as well. And really great news about St Anne's and Elmhurst Road, Paul, because that's for me a real example of invest time and money now, and we will definitely see the benefit of that, and it will move us closer to our strategic objectives in the long run. So for me, that's a really good bit of news, and it lines up brilliantly with our strategy as well. Obviously really pleased to see workforce and agency and our Dorset provider collaborative in the priority list there. It should be for all the reasons you've just outlined, and cost as well. So really good. And I'm really pleased to hear you say that the cost improvement programme, you're looking for assurance on 1/6, because that's a bit of a niggle in my head. It always is every year, back end cost improvement programme savings, and we run out of runway. So really reassured to hear that you're asking for that assurance. It's going to be critical this year because it's going to be hard this year. And finally, at some point, I know we've had a VCSE update in these reports and it's dropped out. The VCSE is going to be a critical delivery partner, and I think it's really important that the VCSE remain on our radar, and we socialise our own understanding of what's going on there, so that when we have to ask, we're familiar with what's happening. So I think an update on VCSE would be really helpful, as well as the usual statutory partner updates in this report.
Can I add to that, because I noticed as well that we didn't get anything from VCP this month. Jane goes out to all the partners at the same time every time we have a board meeting. It's things come back in when by the reporting deadline. If they don't, then they get missed. So does that mean we've got something after?
So BCP declined to comment on this board report because of the pre-election period and the work that was being undertaken with BCP at that time.
Right, thank you. Sorry.
Yes, totally get what you're saying. Yeah, which I'll discuss in part 2, but there's quite a bit of movement going to happen at speed in the next few weeks. But if I can just bring that up in part 2, that's it.
Okay, Forbes.
Just
sorry, I had Rhiannon before you.
Yeah, let Rhiannon come first.
Rhiannon and then Forbes.
Of course.
Okay, thank you. Just Patricia, welcome the emphasis that you placed on that importance of listening. I mean, truly listening to patients as equal partners. I guess the bit for me, the strengthening of clinical governance, the learning across the system, and I know it's a direction Debbie's trying to strengthen further in terms of that importance of learning. The other bit for me is how we can engage, I don't know which other partners, in understanding more about the impact of patients waiting on waiting lists and the potential of avoidable harm. It's an area that I know is harder to get to grips with, but I feel it's an important area that we shouldn't overlook, and we need to continue to find out how we can address and understand what those harms and impacts are.
We need to take that through the quality committee. I'm sure that QSG have done a deep dive.
We've done a deep dive, and the providers have done several deep dives.
Yeah, but it's something that we need to keep looking at. We need to keep looking at together, and I think also there is a question. Clearly, primary care colleagues are very close to this as well, but there is a question about, with our commitment to inequalities, is there more that we could do? For example, people with protected characteristics and children, so that what we're not doing is addressing this problem as the NHS has always done, but we're looking at it in a deep way.
Thank you.
Did you get what QE?
Well, I absolutely understand.
I was just asking, do you know what QESG is?
I do know.
Quality surveillance group.
Where you were directing your gaze. Absolutely aware we've done deep dives, but I think Matt's point is really well made, that there's more that we can do, there's more we need to do in terms of looking at things differently. And there may be some of our academic partners may be able to help us in that space as well, if we haven't looked at that already.
Yeah, and the other thing that Debbie and I have talked about is when we do have our quality surveillance group, it tends to be a lot of health issues that are brought forward, and actually we need to be looking at broader system issues. So one of the things we've talked about a lot is working with our social care colleagues to get underneath what is the harm when somebody's waiting several weeks for a package, to avoid an admission. What happened? How are we reporting when somebody is admitted to hospital because they haven't got a package at home? And actually, what happens when we discharge them with a suboptimal package? So we need to start to think about all of that. So we're looking at harm in the round, and that then informs a different way of working going forward.
Okay, I'm going to take Forbes and then Cecilia, and then we're going to move on.
All right, thank you. Just a brief comment, 2 brief comments really. And it's always helpful to see the sort of state of the nation here in the report, because it gives us a good broad overview. And it would be nice to see a BCP entry, but it is what it is. I just, I'm really supporting Patricia's comments and the words that are coming out also of the new government. But the words do need to turn into actions, and they need to turn into actions quickly. And I can only speak for the out of hospital part. For general practice, very, very disappointed. We speared this at the last board about the financial offer that there is, because there's an expectation of pay increases, yet your offer is 1.9%. There's some local issues which Paul and Rob are aware of, which we will work through. But it's great to say we want to move care out of hospital, we want to move to prevention, we want to move community-based services. But if the actions are not demonstrating that, and they're not demonstrating it soon, things are just getting worse. And I speak from a general practice perspective, but dental is just terrible, really, quite honest. NHS dentistry barely existing, and certainly barely existing in Dorset. Yet another practice local to me has closed its doors this week. Continue to do private care. So people genuinely have nowhere to go to get NHS dental services, and the problems that existed in the dental contract. So I welcome West Streeting going and talking to the dental. Let's hope they can come up with something. Because what you've got is new entrants not going to look at NHS services really to the profession. They'll just go straight to private services. So once they're gone unless there's a
out of hospital, and how that then splits sort of between community and primary care, and also through the locally enhanced services bundle, how we can make it easier for GPs to deliver on the small number of things we need them to without having to go through masses and masses of bureaucracy. So I think we need to think through that. I think there is a commitment from them around shifting a significant amount of care to the open hospital model. And we need to do the work with NHS England to understand what that looks like, what the timeline of that is, because we actually might get the national timeline and what that means in terms of moving the investment envelope. And then keep the national conversations alive around what investment there is into the GP contract, how we improve that, and also how we make the contract fit for purpose. On the dental side, we have an oral health strategy, and I'll talk later on. But Rob and I also had a conversation at SLT last week about the fact that for every other part of the NHS, when we have a capacity gap, we bridge it by using the independent sector. And we should be doing the same thing with our dentists. We should be saying to our dentists, let's talk about part of your private service actually supporting the NHS right now through dental, and what does that look like if we're offering scale to you, and then we can negotiate on a slightly different price. And there's real support for that from NHS England. So I think we need to look at that and take it seriously. We've got the business case that has been developed by the AECC to have a dental school in Dorset, which will be a really good move, because we've really struggled to recruit trainee dentists because the school's in Exeter and it's too far for them to travel. But I also think that we need to think very carefully in the planning round for that of what type of training do we want, because we need to lock in to our contractual relationships with dentists, an obligation around population health, as well as just responding and providing service, so that we can see over a period of time an overall improvement in oral health and oral hygiene. And also that we don't fully understand yet how many of our patients that have currently moved into private dental care will prefer to stay there. And so we need to get that workforce model right. And the third thing we talked about at SLT was, how do we also get assurance around the quality of service? Because we know that when you see an NHS dentist compared to a private one, well, the treatment you receive is identical. Some of the consumables or products that are used are really different. So how do we get to some middle ground so we're starting to get better quality of service provided on the NHS, not just a responsive service provided? And I think all that we need to think about in terms of the negotiations this year about how we move forward.
Rachel, were you trying to come in?
I would absolutely support. I mean, I think there are opportunities, as you say, around children. The access of children to dental care seems fundamental part of childhood development, and we can't guarantee that in the Southwest currently. So I think that's something that we have to own across all of dentistry, both NHS and otherwise. As you just had a conversation, haven't you, about determinants of health? Well, that's one of them. So we'll do all we can to support you, push as hard as you can, actually. And I think the training is also about doing work. It's another means of access. Even though people are training, there's a lot of activity that you can put through things like training hubs.
Thank you. Cecilia.
I just wanted to reinforce the comment about harm whilst waiting. I think we really do need to look and make sure that we do have a handle on what that is. And actually, is absence of a service, absence of available dentistry, absence of a particular service part of poor clinical practice. I think I'd like to understand exactly where that actually fits in. My other comment was around about the opportunities that we have here listed, financial resilience of households, talks about social mobility and all of that. But my earlier point about getting those who are waiting on waiting lists and long-term sick back into the workforce as being probably a quicker win than trying to address social mobility, which has to start with children. Is there a focus here, an opportunity to actually deal with that? it may be in there, I'm just not reading it at the moment, and I think it's something that we really do need to consider. Thank you.
So I think Dawn. No, I was just going to ask a question, but Dawn. I think Dawn responded to that question around getting people who are off sick back into work. But I actually think social mobility is twofold. It's children and adults. We've got adults in our community not so mobile, so we need to tackle both ends of that, and that's really important. And then the other point, just going back to Forbes, is the public health team with Sam are about to do a needs assessment for community pharmacy across both of our local authority areas, though that will be really helpful in informing how we move forward, because we know that some of our pharmacies are really struggling to deal with the new service that's required.
Okay, thank you. It was the social mobility point I wanted to pick up, so thank you for that, Patricia. Going to leave us on. We're running 25 minutes behind now, so let's move on to the Dorset quality report with Debbie, and this is here for assurance, isn't it?
Yeah, thank you, Jess. So I'm going to take the report as written, and hopefully everyone's had a good look at it, and just bring a few highlights to the board that I think is important that you recognise. So this is actually sort of on behalf of all of my chief officer colleagues, actually, to just let you know that we've talked about an integrated quality and performance report on numerous occasions. This will be the last version of this quality report that comes to board. We've had a really helpful meeting this week. We have a plan to have our first integrated quality performance, finance and workforce report. I don't know what we're going to call it, but anyway, integrated performance is the term at the moment. And the new report will go through committees in August, and so the next board will see the new report. So that was the first thing to say. I just wanted to a correction for the minutes, because you see we even get our own acronyms wrong. So actually we don't have the quality surveillance group anymore. We have a system quality group, so it's SQG. So they are the same thing, but people keep referring it to as QSG, which was the old terminology. I just reminded my chief executive and my Ned over there who can't keep up with them. But just for the minutes and for colleagues that are trying to keep up, it's the same thing. So thank you for that. So just some quick highlights. I just wanted to reassure the board that the system quality, equity and equality impact assessments process, that's a mouthful, is actually fully embedded up and running, and we have started to see quality, equity and equality impact assessments go through that process now. So that's scheduled for on a weekly basis, so that we can actually hear things very timely, and we just step it down if we haven't got one. So that's up and running, so to make sure everyone was aware of that. In section 2.2, where we've got the issue around the manufacture of sanitizing hand gel, I just wanted to reassure the board that at the current situation is that our trusts have actually got sufficient supplies for hand washing whilst this is actually being resolved. So although it is an issue that obviously needs to be resolved and the procurement leads are on it, I can reassure the board that actually at the moment it's not a risk to us, and we have sufficient supplies to maintain our hand hygiene for our providers. Under sort of 2.3, the MRSA blood scheme, I just wanted to point the board's attention to this just as a demonstration of how we're starting to see how we can use the patient safety incident response framework, or PSIRF as you'll hear it called, to actually look at something that is has become apparent as an issue across our system, and how we can actually work together to do a system sort of investigation collaboratively and learning event. And we will bring back the learning from that at a future report. But I just wanted to sort of demonstrate that, you know, that it's showing you how we are actually starting to try and use the new framework into actually something across our system, which I think is really positive and really encouraging. With regards to section 2.4, I just wanted, because I know my non-executive director colleagues are really good at looking at the appendix as well, so I just wanted to point point out to you that yes, the patient safety incidents have gone up, but they've actually gone up because we're actually starting to be capturing all of the Southwest ambulance incidents in our Dorset data. So just to make sure that you're aware of that. So that is forcing our numbers up, but it's not because we've suddenly got a massive increase. Couple of positive things I just wanted to point out to you, if I may. We're obviously really pleased with the patient safety audit report results that we achieved. That's given us some assurance around the systems and processes that we're using across our system, which is great. And then also, I'm really pleased that we've actually been able to move forward with our plan and our proposal to actually bring sort of our patient safety team to include primary care partners and really sort of look at particularly general practice as it is at the moment, but focusing on making sure that our quality improvements go across primary care and not just focused on our main providers. So some really good positive work moving in the right direction with regards to that. So yeah, that's all I was going to highlight. Happy to take any questions.
Thank you very much, Debbie. I'm sure there were going to be questions around the IPR, so well done for covering that off first. Lisa.
Slide 9, the friends and family test, the response rates have gone right up. Do you know why? Because usually that's when you've got loads of complaints about one thing, right? Or something's gone wrong. But in this case, the positivity is still up there and the response rates have gone up, which is great. So I'm just wondering why, and is it going to stay there? Because that would be great if it did, because we talked about listening being important.
I actually don't know why it's suddenly gone up, other than what normally happens is it's a primary care practice suddenly having a bit of a focus on it and giving out the leaflets. It's probably something as simple as that, to be honest. We consistently continue to remind our practices around promoting the friends and family test, and I think every so often one or two practices will have a bit of a push on it. So I think it's probably as simple as that, Lisa.
Okay, it's a big increase though. It's like double.
Well, can I just check? That's a year ago, is it?
Yeah.
Right, cool, okay.
I did that as well. Yeah, it is.
Historic data. Yeah.
Okay.
Okay, I don't see any more hands, so I'm going to move us on, if that's okay, to the finance update. And Rob, this is for you. Again, this is also here for assurance.
Yeah. So what we have in the pack is the month 2 system finance reports. The first piece, which is the technical piece, is that the month 2 report reflects the plan that was the original, that was the 21 million deficit. Subsequently, we resubmitted a 20 million deficit. We had to resubmit, including resubmitting phasing. So what I'd ask you to do is not look so much at the variances, but look at the absolute numbers, because absolutes are real, but the plan phasing will change when we get the Q1 reporting. So when we start looking at variances, Q1's the month to start really looking at that. If you looked at the variances for month 2, we're not doing too badly. But as Patricia said, we have a second half of the year step up in efficiencies. That was your point, Lisa, about you'd like some level of assurance around that. So the first thing to note is that we had a 9.3 million planned deficit based on the original submission, and our actual deficit was £11 million. So as I said, it's not too far away, but the efficiency ask isn't as big as it becomes. So you'd expect it to be quite close to the start. One of the tests that we should all do, and does happen, is the straight line extrapolation of the run rate. That's jargon. Effectively, what you can do is you can say, well, if you have an 11 million deficit after 2 months, if you multiply that by 6, that doesn't sound like 20 million. It's more like 60+ million pounds, isn't it? And that's one of the things that we've already started to develop as part of our bi-weekly chief exec escalation, how you can look at your year-to-date position versus the full year forecast and bridge the two. So how can you possibly be 11 million deficit in month 2 and you say you're going to hit 20 million? Something must going to be improving there, isn't it? And how do you do that? Last week we received a letter from our region colleagues. Patricia alluded to it. All systems actually are being asked to provide lots more information and assurance to the region as well. As I said, we're already on the front of doing that internally anyway, where we have to show that bridge. So effectively, you take the straight line forecast and then you say, what are we all committing to do to get it back to 20 million? And if you were rag rating those things that you have to do, what's green, kind of in the bag, we know it's going to happen. What's amber, we know what we need to do, but we're working quite hard now to figure out exactly how we're going to do that. And then what's red? And the red could be very high risk schemes, or it could be unidentified at the moment. But this part of the year where that is still, it still happens that you do still have some unidentified. So all of that's in train. We look at on a bi-weekly basis at the System Recovery Group that Dean chairs. We look at the cost improvement programs and the amount identified versus unidentified and the delivery of that. So we have that every 2 weeks. And from that, there's a chief exec escalation meeting afterwards where we raise with the chief execs things that we're concerned about. Now, it doesn't mean everything's perfectly brilliant, but what it means is there's a lot of visibility around it. At PPC, our performance production committee, at our last meeting, we started to report a risk-adjusted position as well, which shows the kind of what I've just been talking about, that forecast as well. So we're trying to expose that, and the idea is that every time PPC meets, Productivity Performance Committee, that number will start coming down and down and down, and you'll see it bridging towards the 20 million as we fill the hopper up with schemes. There are green shoots as well, so you will remember we already talked about agency being a focus. So agency we are doing well on. There's lots of greens on the agency chart, green being good. So at the moment we are doing well on agency and bank, and also in our providers, their efficiencies, their CIPs as well. In the first couple of months, although there's a step up at month 6, they are delivering, if not over delivering on the efficiencies. We do still have other cost pressures, hence that we've come off. So we still have some beds open that weren't in the plan, etc., which does impact on agency as well. And then within the ICB, you know that from a financial point of view, the costs that are associated with PHC, they're not necessarily all PHC costs. They end up RDOCs. We might not have all the right services in place. The early signs are that we've arrested the rise, and it looks like we're now getting it more flat. So if we took last year's outturn, first thing would be, can we keep that flat, what we call flat cash, and then we have to see if we can go further. It's looking like the tightening stuff that Debbie's team are doing. It looks like we've already swallowed the price increase and still kept it flat. So that's really, really good. In terms of if that continued through the year, that would be a cost avoidance of 17 million that the team were originally predicting. That's fantastic. We still got to go further though. That's the issue. So I say there's green shoots. There's lots of focus on, as you were saying, Lisa, the twitchiness around. I'd like some assurance around the CIPs. That happens on a bi-weekly basis. We've got different things coming in place, and we're having to report into the region actually by next Friday the full answer to the letter they've sent, which includes a lot more than just this bridge on that run rate. It's a lot more information around financial governance, financial controls, what processes in place, how you can find the capacity to identify all these savings needed, how you've got the capacity to deliver the savings, all of those sorts of things as well. Okay.
So Rob, the exam questions that your paper's here to answer is how well the system is performing financially. I think you're saying it's okay. There's some green shoots, and you have more visibility, and you're giving the board more visibility around what's happening through the various things you have in place. What's the answer to things that need to be escalated to the board? Is that the PHC stuff, or is it something else?
We're looking at PHC now every time at PPC as well. I think we're really just updating the board here on all the things that are in place to give those early.
Because we don't want to be in a position which is you always shove your savings at the back end of the year and then don't deliver them. And so that's something, Rob, if you agree, we can do at PPC.
First of all, I've been the biggest acronym user. For anybody who doesn't know what that PHC is, it's Personal Health Commissioning. Whilst we don't want to, there might be things to escalate as yet, because I said Q1's fine, we do need assurance. But also, it's probably, I think, worth noting that Debbie's going to bring forward a paper later on personal health commissioning. Sorry, I keep forgetting how old you wrote down.
It's not like you to talk quietly.
personal health commissioning. And if we're going to get underneath the skin of the significant rise in PHC costs, all of our partners need to lean into this. We cannot solve this by ourselves. So we're going to be asking for partners to take certain actions, which are going to be challenging for everyone. But unless we all lean into this problem, we're not going to solve this one, because we can only tackle a certain percentage of what we're spending on packages of care by the actions we take. The rest of it is about what all of you do in line with policies and procedures that will get us to the right place at the end of this year and continue to get us to the right place. Because if we don't solve this problem, we will not be able to serve the really vulnerable people that we need to serve, because we're spending far too much money on individual packages, and so it's driven by the decisions that are made outside of the ICB.
It's a really good example of where we working together can actually work for the benefit of our communities, isn't it? So thank you for that. I'm going to move us on then to system performance report, which is the other side of the finance and works alongside it. So over to you, Dean.
Thank you very much. So this is the first report since we have signed up our operating planning for the year. The number of things that we are now reporting on has significantly increased, because during the H2 planning process, H2 meaning the second half of the year that we had last year, the number of metrics that we were being asked to deliver kind of got prioritised down to about 10 main ones, and we're now back up to the full suite of operating standards, of which there are 54 at the moment. That's quite a lot to keep track of. We've been through a prioritisation process based on a risk assessment of which are the standards that we need to kind of keep our priority looking at kind of on some of these on a daily basis. There are 15 of those, and as you go through the report, they're the ones that are highlighted in bold are the ones that we're looking at. Not that we're ignoring the others; they're still form part of this performance report, and we have a process to look at each of those. You'll notice, as ever, there is a lag of data in here, because the validated data sometimes is kind of up to 2 months behind the actual reports that we need to look at. So what we've done this year is we have a forward look report, and on page 87 of 394 that's in your packs, that is the forward look, and we look at kind of the most the 2 most current months, but also then look forward to the end of either the current month or looking into the next month, so that we're predicting where we think we've got problems and where we need to address those. So if I go on to the content of the report and kind of things that worry me, things that kind of will worry the board. So first of all, no criteria to reside. We've been reporting this ever since we have existed as an ICB. The numbers are the lowest, though, that we have seen since we have been in existence for 2 years. We are at the end of June down to about 250 but we have a target of getting out. We're not quite there, but we are considerably lower. You might remember some of those days where we were up at 370, no criteria to reside. So we are better than that by over 100, and that's through sustained work that we have been doing across the system. So what gives me kind of hope and the optimism for that, and I think evermore I am more optimistic about our way that we are approaching these, because of the way that we're now working as a system. This year we've reorganised around the 2 places, so around the Bournemouth, Christchurch and Bald place with University Hospitals Dorset, and with Dorset Council and Dorset County Hospital as the second place. We've focused our effort around 5 priorities. We've kind of honed those down to 5 things, so that we're only doing them properly and going into some depth. We've also brought in some external support, and we've got 3 support offers currently working, which are proving to be really successful. And that is what is really giving me some hope for the future. And we've got a fourth area where as a system executive group, that's where all the local chief executives come together. We are now in a process for looking for a strategic partner to help us with that urgent emergency care pathway, right through from prevention through to discharge from hospital. And that will conclude over the next week or so. For long waiting patients, at the end of June, we have got it down to 2 patients waiting over 78 weeks. Those patients will be treated in July, and as things currently stand, there are still 75 patients to treat to get down to treat them all by the end of July. All of them have got dates, and we're expecting to treat them by the end of June. So that will be a key milestone for us, the system. That'll be the first time we've achieved no patients waiting over 78 weeks. So after that, we'll be on to looking at the 65 weeks, and we aim to treat all of those patients who'll be waiting 65 weeks by the end of September. So there'll be another milestone, and that is the annual plan commitment. Also want to mention, because we mentioned children earlier in the meeting, there is a particular focus on reducing the waiting list for children who are waiting over a year. We know we have got some really long waits for some of our services for children, so they are included in our long wait work as well. During the board assurance framework, we talked about the elective recovery fund, so the ERF. This is a reporting that is 3 to 4 months behind reality. So we are producing a kind of a report that we can look at on a monthly basis, so that we know where we are, or try to predict where we're going to be with that. And we've got the first reports of that, and as Rob has mentioned, we look at that through the system recovery group every 2 weeks. The other area I wanted to mention was the dementia diagnosis rate. We have not been achieving this standard for some time. We have got a plan though now. We're working that through in terms of what that means for how soon we can improve the dementia diagnosis rate, but we are targeting the group of people which are currently underdiagnosed and exploring this by PCN as well, where there is a big variation between different PCNs. There isn't anything to escalate to the board, but I wanted to give the assurance on kind of how we are addressing the performance, and also the current issues that we've got within that report.
Thank you very much, Dean. And similarly, some green shoots there. So Matthew, then Patricia, then Kate.
Thank you. So thank you, Dean, for a really clear report. Thank you for all the work that you continue to do with teams across the system, which is much appreciated. I'm going to keep the sort of theme going from earlier discussions about thinking about how as an ICB we can make a difference for some of the most disadvantaged in our population. So I have two requests, which perhaps rather than answer now, they could be taken away to see if they are helpful. So one is, for no reason to reside, my request would be, please can we have parity of esteem? So there are 22 recognised no reason to reside patients today in our mental health settings, which is quite a significant percentage of the bed stock. And I think, for example, on slide page 105, where we've got our trajectory, I believe that we should have the mental health numbers there. I think that's really important, and perhaps we could consider that. And then the second would be, it's sort of similar to our discussion about waiting lists, but my second question would be, I wonder if we should take a look at who our no reason to reside population are, compared to our total population. And I'm wondering whether within that, in terms of some of the long delays, we might also see, for example, some markers of deprivation.
Okay, Patricia.
So I think that's a really good point, Matthew. And we've also talked about trying to understand whether some of those individuals have been admitted because in some way there's been a fairly package. Sorry, Dan. Yeah, we talked about the fact that we want to have a look at whether some of those individuals have been admitted because there's been an issue with it, and how we can learn from some of that. What I did just want to flag, which I know Dean is working on, but I am increasingly worried about, is no criteria to reside in the BCP area, because we have now got some individuals that have been waiting up to 50 days for a care package, and that worries me because they're in the wrong setting. The longer they wait, their chances are they will decompensate, their health will deteriorate, they are more likely to get a hospital-acquired infection or fall. And we also means that the longer they wait, they're more likely to go into permanent long-term care. So we are not serving those individuals well. And we need to understand why we've got waits that long for external packages and what can be done. Change that, because we're not fulfilling our duty around responsive care.
I've got Kay, then Siobhan.
Thank you. I wanted to ask a little bit about the theatre utilisation, because that's been on the reporting for some time, but I know it's not one of the big headlines. And reading through this, I wasn't sure at the end of it what it is we actually need to do to change it, because it talks about there being monthly assurance being sought, but what is the key issue here, and what is it that you want to see change so that the outcome is different? Because really, you're quite right, it must have a massive knock-on effect on all these other outcomes that we are measuring, and this is an enabler that, if we got it right, could push the system into a better place.
Shall I just bring Siobhan in, and then you can respond?
I might get Dean's help to respond on theatre utilisation. So just my it's quite interesting, because I wasn't sure what Patricia or Matthew were going to say, and actually, as we've had the finance report and then the performance reports, we also probably internally, we have our ability to look at month 3 in the first quarter, and actually we've described it as green shoots, but actually I would say there's some momentum which actually is positive, and actually the board, it's really good for us in the ICS to realise that and acknowledge it. The issue around no criteria to reside, my concern is probably that as a system, and even within our organisations, you can get to a point where this is normal. And I still have 186 patients with no criteria to reside. And I still, when I first came into the Dorset system, I remember thinking, oh, we've got to sort this in the next 3 months, because it's not normal, you know. And actually, I just want to reiterate that message. I know we're doing some positive work and we're going with strategic partner, but actually, this is like one of those wicked issues in Dorset that I think for all of us, the benefit, it will have such a positive for patients, for families, for our residents, and for our providers, for our performance and our money, that actually the onus is on us to absolutely make this opportunity that's coming towards us work. But I don't want us to normalise it. And I suppose I'm a bit in a space where we've made improvements on our 4-hour performance, but actually 76% isn't right. So I would like Dorset to continue to be, you know, quite challenging conversations about actually this isn't normal. We want to be better than this. And I just felt I really needed to say that. And also we need to celebrate when we get things really right. And I know I'm part of the system, but UHD getting to 78 weeks with a 0 is a milestone for UHD. And I know my colleagues at Dorset County are very close behind, but it's really, really important that we celebrate when there are certain aspects in the system that have gone well. Around theatre utilisation, it's one of the support offers, I think, Dean, we will say that we have. Dean and I were at a performance meeting in Dorset where Professor Tim Briggs called us out as a system, not for a good reason. We're sort of in the lower decile of performance on theatre utilisation in the southwest. That is not for the want of trying. And actually, this is quite complex in different specialties, often around demand and capacity. Some of it is cultural, around how lists operate and what happens. Some of it is around fundamentals like building works, decanting, stuff like that. But I'll pass over to Dean to say more.
Yeah. So I think a couple of things to say, kind of on
on no criteria side, kind of very much, we do monitor kind of on a daily basis the mental health ones, and I neglected to say in my introduction as well that we have seen such an improvement in the numbers of patients who are not just kind of waiting to come into hospital. I think we are down to 8 yesterday, which is in single figures, which is significantly improvement. And when we had our national review with the Department of Health and Social Care earlier this week, they were really congratulating the Dorset system, particularly on the low numbers of mental health patients that are either being treated out of area, of which we've only got 3 at the moment, and 8 to come in hospital. Now, we know that is still 8 and 3 too many, but it is an improvement from where we were. And on the operational escalation level, so that's a scale from 1 is best, 4 is worst. We have moved from a 4 over winter to a 2 consistently now in mental health, so that's significantly improved. And take what you say, Matthew, to include the mental health ones in here, and also look at those inequalities that there might be people that are waiting to leave. I think it's true to say we've had particular success with patients who are leaving hospital to go straight home with supported packages, and coming out of Dorset County Hospital now, we are achieving that in virtually every case within 5 days, and 5 days is the longest length that we're seeing there, and we monitor that on a daily basis. So that is a real improvement that we've seen. Still some improvement to get at UHD, to get those out at the same time, but they're learning from what's happened at Dorset County. In theatre utilisation, I think the other thing I'd say, rather than just the 85%, yes, the 85% isn't where we need to get to, but what really counts is the number of people that we can treat through theatres. So it's not just looking at the theatre utilisation. There are some characteristics at the moment with as Siobhan has said, building works the same at Dorset County as well, which is kind of holding that number back. But there are things that can still be done to get to 85% now and treat more cases as we go through. As we bring on the Weymouth theatres particularly, that will improve, because that moves around where we can do different types of operations, particularly the more complex orthopaedic ones that can be done out of the Weymouth theatres.
Right. Well, thank you very much. Thank you for reducing our overrun by 10 minutes. We're only 15 minutes behind now. Good. So we're going to take a break for 10 minutes. If we can come back 10 minutes sharp so that we don't get any further behind. Can I just ask, though, the owner of the vehicle MV60 OJZ because that's quite significant, isn't it, to have somebody in hospital for 50 days that actually has no physical reason to be in hospital. So, Gillian, I'm just wondering, what can we do to get beneath this and get this resolved?
Hi, Jenny. Well, I think we're doing all that we can do across the BCP system on everything to do with discharge. And we had a review meeting relatively recently where we took stock of all of the 5 actions that Dean described and the progress that was going on and the impact that it was having. We concluded that we were partially through the implementation of the actions and so needed to continue with them, but also needed to take stock quite quickly again. And Dean, I know we need to get that meeting back into the diary on what impact it's starting to have, because on the review of the data that we did at that point, we weren't seeing impacts from the actions that were in train, and we knew that we needed to understand that. Excuse me. And then we're bringing in the strategic partner that will help us to get under the surface of the whole thing. And I think, you know, we can all pick out different individual bits of the system's performance, but what we really need to do is get under the surface of the whole piece and see what actions we can take together to move it forward. We're as committed as any other partner to shifting this and to making sure that people are getting the right standard of care. Excuse me, I'm suffering a bit myself today.
Yeah. I wasn't actually asking about commitment. I was just asking about the actions, because this is one of those things, isn't it? It's not about whether or not we think it's we're committed or not. We actually need to be doing something, and 50 days just feels like a really long time. Patricia.
Thank you, Gillian. I just want to ask that, can we make sure that whatever investigation we're doing, we actually do that rapidly, because we have got patient harm as a result of that, and also that yes, we've got Newton coming in to do the review, but actually if we don't get on top of this before we get into the throes of winter planning, we're heading for an incredibly horrible winter. And secondly, we're also heading into a place where very likely BCP will UHD will have to open escalation beds, which we cannot fund within our system. That means we'll be moving away from our deficit plan. So, and that's not where we want to be, because if we move away from that deficit plan, I'm really clear now, we will end up in segment 4 and we will lose our power to make decisions for NHS. So we need to get on top of this really quickly.
So, Dean, the strategic partner piece that Gillian's just mentioned is your hope that this is what's going to help to unearth additional things that can be done beyond what we're doing?
Part of it, but the strategic partner is kind of a medium to long term solution to this. There are things that we need to do now. We have got, and there is a support package that we've got in at the moment, which is what Tricia just referred to in terms of the Newton support that we have got at the moment, which is through the Department of Health and Social Care, looking at our transformative care hubs. They are in this week with our 3 transfer of care hubs. So transfer of care hub is where all of the discharge teams come together from the hospitals, from the community and from social care to plan the discharges for anybody needing a supported discharges. That review is in place at the moment. So I think that will be the first stage of how we improve and reduce those times to hospitals. So I'm expecting that kind of next week will be a report from those. So I think it's a layering effect of this. So we've got our own actions that are in place, and I'm going kind of shortly straight into our weekly meeting where we review all of those 50 pages, those over 50 days. We've got the transfer care hub work from Newton that is happening at the moment. We've then got the Better Care Fund work, the support package that we've got looking at our discharge to assess processes that is reporting this week. And then we've got the strategic partner that will come on hopefully in either later this month or next month with their diagnostic work, which will help us then with the future improvement work that we need to do.
Okay. I know Gillian wants to come back in, but I'll also see if Siobhan wants to say anything. And Forbes, I know you've got your hand up. So, Gillian.
Yeah, it was just to say if there are further things, Dean, that you think we need to be doing in between the ahead of the stock take that we've agreed to have, then let's have a further conversation offline about that and what we can do to move it ahead. It may be worth the board having an update from the team in the round from the BCP area next time. That's something that we could pull together so that the board has a sort of deep dive from the collective and is able to test and challenge with the individual partners. I know from BCP Council perspective, we'd be very happy to contribute to that rather than Dean telling the story overall. So happy to bring that back to the following board if that would be helpful.
I think that'd be really, really good idea actually. So if we can get that scheduled for the next meeting, I think that'd be helpful.
And I'd really support that, Gillian, because the teams on the ground, this is not from the want of not working together, because they are, and actually I think people are quite hopeful about the sort of more strategic piece, that actually it's going to really just really challenge us and make us consider, is there anything else? What is it we're not doing? And is that something to do with the fact that we have all worked together for so long? There's really interesting things that I think that hopefully will absolutely help us with. So very happy to bring something back together.
I think it's really important because I know it's one of the things that certainly MPs, previous MPs have judged us on, that you've come together as a system, but actually people are staying in hospital longer than they need to, longer than they were before you came in. So I think if we can do something to get on top of that.
Yeah, just to comment back to Siobhan's comment about we must be very careful not to normalise the abnormal.
Absolutely.
And, because we made a bit of progress, and I fully support that, that doesn't make it right. And I think particularly for children and young people, in the mental health rates that they have, often quite low level intervention from mental health in anybody's life makes a big difference. And if they don't get that, then it actually, in terms of long-term health outcomes, they won't have a successful life necessarily in the way that they would want and we would want them to have it. And actually the cost to the system is far greater long-term. And when I refer children, and we've got very distressed families, very distressed children who are waiting times are not days to weeks, it's months to years really, and a lot of it's years at the moment. I think we've got to pay a lot of attention to that. Obviously.
Great. Okay, so we'll agenda it for the next meeting, and we'll get the teams to come and do that. I'll take you to the last one, and then we'll move on.
I suppose I just wanted to round up the conversation saying that this is not about whether people are working hard.
No.
It's about the fact that what we're doing is not producing the right outcome. And if we know that, then we need to stop doing what we're doing quickly and do something else. Because our priority as a board is to make sure people get safe and effective care, and right now they're not doing. We signed up to a set of principles in the ICB, and one of them is pace, and we move too slowly. And we've also agreed in our joint forward plan that one of our key objectives is to make sure that elderly people have long and healthy lives. And we're keeping them in hospital 50 days waiting for a care package. We are not honouring that principle. So we need to hold that at the centre ground of what we're doing, and not whether our people are working hard or not. It's whether they're working hard on the right thing.
And so perhaps when they come to the next meeting, they might come with some questions of things that they are all thoughts around things that they think we could be doing differently. We can either support or not. So yeah. Okay. So let's move to the committee escalation reports, and I'm going to start with Dan for the Productivity and Performance Committee.
Thanks. So there's nothing to escalate from the committee. The board's had the same finance and performance updates that the committee had, so I won't go over those. And as already been referred to, there's some work ongoing on PHC, public personal health commissioning. I guess what the committee had just told the board is that the level of effort and the grit has been a real shift, and so great to hear the numbers, but there's more work to do. But there's been a real change in grip, and I know there's a key paper in part 2 which relates to that. And then the final thing, I just refer people to the top box, a really good conversation on the infrastructure strategy, and I know Rob and his team will pick this up in the introduction of the item later, because for it to come to board today, there are 2 clear steers from the committee around engagement across the system. and the difference between the strategic approach and the plan, and that work's been done. I don't propose to pick that up now because I know we'll do when we get further down the agenda. Happy to take any comments on it.
Thank you. Questions, comments? Okay, shall we move on then to people engagement culture, which is Lisa?
It was a big pack, and it was a big pack because we had a really long conversation about the information that needs to come to the committee and how the integrated performance report and the workforce performance report, how they interact and what we need and what we don't need in duplication. And it did go on for a bit, but I think it needed to. But the action from that was that the committee leads and the chairs would meet to try and untangle that and figure out what we take and what we don't. I know that meeting went in the diary, but then it came out again, so I'm assuming it'll get put back in at some point because it is important that we understand that. I always like to see things come early, really early stage thinking to committees, and the Dorset Medical School came early, and it was a really nice paper to see, and it was great to have it at that early stage because it's on our radar. A really good report, Kirsty's sitting over there, a really good working in partnership with people and communities report. Great report, lots of stuff in there that you might not know. So if you haven't seen that, Jenny, I know one of the things that you talk about, as do I, is engagement. Where's the engagement? And that report was just a really great example and a really great articulation of the engagement that we have on lots of levels with lots of different stakeholders out in the community and people as well. So if you haven't read that, I really recommend that you get a copy and you read it because it makes for good reading. We had the risk register as well, and whilst there's nothing for escalation, it's worth talking about the risk. We didn't approve the risk. We had a risk come to the committee. We didn't approve it. It was too big, needed a bit of fine tuning and a bit more focus, and it actually needed splitting out into two. So that's gone back and it will come back again as two risks around recruitment and retention and running cost targets as well. So that's it really in the headlines.
Thank you. Questions, comments? Prevention, Equity and Outcomes Committee, Kate?
Yeah, nothing to escalate specifically to the board. We had very good updates on specialist commissioning and the issues around that, Dorset Women's Health Programme, community and children and young people's mental health transformation, which was particularly welcome. This is one of the issues that we've been looking at for a long time, and about oral health, investing in oral health and dental access. Out of that came a recommendation that when we are looking at the risk we are trying to formulate around GP sustainability, we should widen that to be primary care. And so we should be also looking specifically at the risks around pharmacy, optometry and dental, rather than it simply being GP. And that risk will be coming to the board next month. Kate assured me this morning.
That's really helpful because it picks up on the point that Paul's raised earlier.
Yeah. So that will be with us next month.
Okay, questions, comments? Quality Experience and Safety Committee, Rhiannon?
Thank you. Nothing to escalate, but I will just say we were in quorate, which was obviously unfortunate. So hopefully we can move that forward at the next subsequent meeting. Debbie obviously has already referenced the patient safety incident response frameworks, and I think it was really good to see that embedding and seeing the learning coming out of that, and again with Debbie's leadership more in terms of that system learning. We had a helpful update in terms of maternity and neonatal system quality update, and still awaiting further inspections by the Care Quality Commission, and just ensuring that we're focusing, and in the context of People and Culture Committee, focus around staffing levels in midwifery, but also in obstetrics as well. We asked for a specific report because there's been quite a lot of discussion around the special educational needs and disabilities improvement plan and the approach that we collectively are taking. It was a really helpful update. I think the main focus is to continue very much in that sort of focus on cooperation, collaboration and outcomes. We received an update around children and young people's mental health transformation. I guess some of the issues that Forbes touched on earlier, that Thrive model really is about those early interventions to help the things up further upstream so that we don't have the poor outcomes for children and young people later on. We also had an update around medicines quality, and we heard particularly around the polypharmacy opportunities, I'd say, both in terms of improving outcomes for patients, but also in terms of collaborating with the clinical networks in terms of where some gains can be made in terms of spend on in the area of pharmacy as well. So that's all I want to report on that. Thank you.
Thank you. Questions, comments? Risk and Audit Committee, John.
Yeah, good afternoon, everybody. So Risk and Audit Committee had no items for escalation. Can you hear me okay in the room?
No, wait just 1 minute. Patricia's got a question on the last one.
I want to understand the quality issue, because if it's me, I shouldn't be in the core numbers of any of the committees.
I just got a note on it, so we can pick it up outside.
Okay.
Yeah.
It
wasn't just you. Yeah.
All right. Okay.
Okay. Go on, John.
No problem. Yeah, so good afternoon, everybody. So we didn't have any significant issues for escalation to the board. The escalation report here taken today covers 2 meetings on the 20th and 25th of June. So the team were working so hard to get all of these matters together. The first thing that we did, of course, was we went through the final stages of the assurance processes for review of the annual report and accounts for Dorset ICB for last year. That was then taken and recommended for approval to the board and subsequently signed off at that session. In going through that process, we heard from management, we heard from internal audit, we heard from external audit, we heard from counter fraud, and had a robust conversation in it being able then to recommend to the board. So that was key activity number 1. We had a more business as usual agenda at the session on the 25th of June, and of course went through the key matters around our risk register and emergency preparedness, resilience and response documentation. So a lot of conversation there. There was one matter that we cross-referred, not as an escalation, but a cross-referral to the Quality, Experience and Safety Committee, and that's around what is known as PSIRF locally, but that's the Patient Safety Incident Response Framework. And we had a very useful note written by our internal auditors, and we were just keen for that to go across to the Quality, Experience and Safety Committee for them to come back with any matters of note or assurance. I'll leave it there, Jenny.
Thanks so much, John. Questions, comments? Let's move on then to the items that we have now for decision.
Strategic Objectives Committee.
Oh, sorry, Kay. I've got it open here thinking that I've already done it, so apologies, Kay. Strategic Objectives Committee, Kay.
We didn't have anything specifically for escalation to the board, but you'll see that we have 2 things that were coming to the board for discussion. Firstly was the board assurance framework, which we have dealt with on the issues that were raised here. And secondly, the inward investment strategy, which is coming to the board for approval. We did receive the inward investment annual report and noted the highlights that were in those. We also had an update on the kind of dashboard that we might want to see linked to the little strategic portfolio management dashboards, and we're feeding back on that. So that is still in development. And we received the delivery plan from the Health Innovation Wessex, which led to very good discussion with our partners on the issues there. The only other one is that we reviewed the risks with regard to the electronic health record. And wanted to see a slightly more emphasis on the strategic elements of this risk rather than the operational.
Thank you very much. So, and apologies again for missing you out. Dan?
I don't know what Kay's prizes for the most succinct report out of the committees. Is there one?
What, do you want Kay to get it? Okay, all right. So let's move on to the items that we've got for decision. We probably will have to allocate the times that have been, we probably will have to use the times that have been allocated to this, which means that when we get on to the items for noting and discussion, that I will curtail that because we are running behind. So Starting with the first one, which is the lead commissioner, 999 lead commissioner and governance update. Which I understand you're going to give.
I'm going to take it because Kate has been the lead commissioner, kind of under our lead commissioning arrangement. I'm here as the Dorset representative of the on the ambulance partnership. So kind of these are the terms of reference for the ambulance partnership board and the decision making body that has been set up, for which Dorset is the lead commissioner, and we're a member of that. So we're taking these terms of reference through all the boards to ratify the terms of reference and the delegation agreement that is in place to us, other part of the organisation, to do that. We kind of oversee performance in that role, and also set the strategic direction and work with SWASO over their strategic direction. The performance issues with other ICBs is not the responsibility through this, that is through the team. So that that's how that happens when other ICBs are off, say, on their ambulance handover plans. Then bringing us here today for agreement in terms of reference and the delegation agreement.
Great. So questions, observations, comments? I think we'll have to go straight to approval. Dan?
It's kind of a link question rather than on Dean's ask. I just wanted to understand that switch from coordinating to lead commissioner. Was there any cost implications for this ICB? And if so, do you recover them across the region? And so it's kind of slightly outside of the paper, sorry, Dean, but it was about that coordinating to lead. And it was just a name change, it's just a name change, but I wanted to understand that.
We expanded from all systems, all ICBs, in order to support us in our lead commissioning role. We did have that when we were the coordinating commissioner, but it is yes, we did. We did. So we've just formalised. There is a shift and a change between being a coordinating commissioner to a lead commissioning role, and which is why we've really focused on making sure that we get the governance right. And actually the operational delivery and support and the infrastructure in place to make sure that we can fulfil our obligations as the lead commissioner. And I guess what we're working through at the moment is, of course, clarification our role as lead commissioner and NHS's role, of course, as working alongside us, but they have an assurance role. So we're working through that.
Kate, the short answer is it's a name change, but you're trying to sort out governance to make a difference. Okay. Debbie? Sorry.
Not just a name change, it's a complete change in responsibility, because when we were coordinating commissioner, all we could do was do by consensus and coordinate views. Our role as lead commissioner is very different. We have a step change in authority of making decisions on behalf of other ICBs.
Well, what's consistent is that all cost recovery.
Yeah. Okay, Debbie.
Yeah, thank you, Bruce. But really recognise what you said just now around the fact that this is obviously terms of reference for this committee, and it doesn't actually cover the arrangements for performance managing of the system. I suppose my question is, is there a documented process for that with NHS England maybe, and if so, where is that being shared? Have I just missed that personally, or has that been shared, and if so, could it be shared again? Because I'd really quite like to look at that so I can actually input.
So there's something that is being looked at, been circulated for agreement on the comments on roles and responsibilities that's been done. So I'll make sure you've got a copy of that, because it's just it's in the consultation phase at the moment.
That'd be helpful.
Because I think there is an issue of kind of roles and responsibilities. We've talked about kind of the quality oversight of the kind of the ambulance service, because it won't be Dorset's responsibility to oversee the quality that is happening in other ICBs. It will be for their arrangements that need to be in place.
Yeah, I think that's really helpful. It's just that I sit on the touchpoint meetings with the Ambulance Trust, and obviously where we discuss performance quality, and it's just be good for me to see the sort of documentation, so I know where I should be escalating, what I should be doing, because it's quite hard to sit there and listen to information that you then don't have any sort of you're not empowered to actually act on. So yeah, so yeah, some documents like that would be really helpful, and I'd be happy to link into the consultation. That's great, thank you.
Okay, so are we happy to approve the terms of reference and the delegation agreement? Yep, seen several nods, so thank you for that. That then moves us on to the Dorset ICS infrastructure strategy, which is you, Rob.
So I'll very quickly introduce Mike Gravel. Where's he from?
Hello, Michael. He's at the end.
So Mike's been leading this on my behalf in co-designing this infrastructure strategy. Mike will talk you through it. There is a key date, which is end of July, isn't it?
Yes.
We're not 100% sure. It's not clear if we have to publish this on the website or if we have to submit it to NHS England. But either way, we have a requirement that we have to have agreed the infrastructure strategy as it is by end of July. Hence, it's coming to this board. It has been to Productivity Performance Committee. It has been socialised fairly widely as well. But if I can hand over to Mike, can you just describe the process and what it is?
Yeah, happy to. Thank you. So as Rob says, we're bringing the ICS infrastructure strategy here for your approval, please. Just briefly background. So the strategy is very much the first phase of our work to develop a full system-wide approach to how we plan and utilise our collective estate to maximise the benefit for our population. It is an NHSC requirement, as Rob has said. We need to submit this by the end of the month, but the reality is we want to be doing this ourselves anyways. This is very much a Dorset piece of work. It's been done in full collaboration with estates leads from all of the organisations. So from the trusts, we've had good representation, also from GP Alliance, and to make sure primary care voice is heard as well. The strategy sets out how we will use our estate to support our ICS priorities and the joint forward plan and our long-term vision, particularly emphasising the need to support primary care and community care with how we develop and utilise our estate to the maximum benefit. For those of you who've seen this document in previous meetings, this version is slightly different in that this is now very much the strategy part. The previous versions also included what was more of the plan, which was the detail about the individual schemes that we're proposing would need to be developed and the detail of the prioritisation. This document just sets out how we've approached that, the rationale for the prioritisation process we've gone through, and some of the broader context of the total size of the scheme and the challenge that we're facing in terms of developing our collective estate. That plan, the prioritised list of schemes will still need to be worked on. The ambition is to have that agreed up sometime around September so that it can inform 25-26 planning properly, and that will clearly need to be done in collaboration with all parties. The particular challenges for the estate is the total estimated value of the schemes that we've identified as appropriate for working on is around about 720 million. Now, a lot of that will be appropriate for any potential pots of national funding or other funding sources, but as a system, we only have 60 million estimated per year of our own capital that we can deploy against that. So clearly there's a very big gap, and hence why the prioritisation is so important about where we focus our work. But that capital isn't just for estates. There's a need to support IT, transport, equipment as well from that relatively small pot. So that's the challenge. We have a small amount of money that we can prioritise against the plan going forward. And we need to do that within the context both of local and organisational priorities, particularly around backlog maintenance and critical risks there, and the system ambition, as I've said, around primary care and community care and developing our estate in the right place. So the next steps will be to work on the prioritisation, get that all approved, and to engage more widely with other partners in the ICS. To date, this has been an NHS-focused piece of work, but that is not the intention going forward. We will work with local authorities and other the public sector, voluntary sector, to make this a broad ICS infrastructure strategy that supports us collectively going forward. So that's the ambition, and that's what's described in the strategy that I've brought here to you.
Okay, so we're going to go to questions and comments. I'm going to go to Patricia first.
So thank you, Michael. Led a really good piece of work. Thank you. Document's brilliant. I think there's just some context that we just need to understand before we start the conversation. In that we talked earlier on about some of the really difficult decisions we're going to have to make in the next year or two, and capital's one of them. So until there is a successful conversation with government about the current NHS capital regime changing, we are stuck with what we have. And what's really clear in the manifesto, and really clear from what the new Secretary of State has said, is very quickly they're going to move into trying to shift the model of care into the out-of-hospital model. And that means we need to make sure that the facilities that we will use to support that around integrated neighbourhood working are fit for purpose. I think the other thing we need to just bear in mind is, well, so we've had a huge amount of investment, hundreds of millions in the new hospitals programme in Dorset, that has not addressed some of the secondary care backlog estate issues we have. So we have a really difficult conversation to have going forward about prioritisation. We need to do that on a risk base and also make sure that our facilities are fit to provide the services we've committed to over the next 5 years. And in that context, some of our GP surgeries are not fit for purpose anymore, and they need to be, not just in order to deliver the out-of-hospital model, but also because we've committed to a number of new training posts within the NHS long-term plan, and currently we can't honour that commitment because we've not sufficient space in primary care to do so. Now, there are some options around the one public estate and how we use that, and for some of our GPs, the hours roles are actually operating out of community facilities that are community asset owned as opposed to GP practice. But we need to be realistic in terms of the amount of capital that we use. Yes, we have to prioritise on a risk basis, but we also need to make sure that we're doing that in a way that is fair, that recognises where investment has taken place in the past, and that we are making sure that we have a estate that's fit for purpose for that out-of-hospital model. Because until we shift the model of care, we can't move into a place where people are seen in the right place at the right time, and the actual model of delivery becomes more affordable. So I just wanted us to have the conversation in that context to make sure we're not going off on a tangent and not realising where some of the priorities are missed.
Okay, so I'm going to go to Dan next. Just to say though, I think that outline would be really helpful in the cover paper. And I do want to pick up on the cover papers later, because I think it would be really good if we could have some of that context to steer the discussions. So that was really helpful. Dan?
Mine was just a comment, and Patricia kind of stole my thunder. I tried to reiterate the committee's view. Thanks to Michael for a really good, clear document. It's really readable and is engaged with, and that was a theme across the committee's discussion. And I just thought it was worth mentioning in Board C.
That's a very minor comment in the context of that, but just to demonstrate I have read the report, Southwark's house in there. It says that I'm delighted my former office buildings refurbished Dorset County Council. It was never Dorset County Council's office, it was West Dorset District County Council. It doesn't exist as an authority, neither does Dorset County Council anymore. So it's just
should remember that with the amount of stick you got for those offices.
The amount of stick, well, it was my inheritance rather than my legacy. I wasn't there when they were originally built. I came a year after they arrived, but I'm really glad to see they're being used. Yeah, Dorset County Council says no, they don't. It doesn't exist as an organisation.
But we probably need to make sure that's accurate in the result.
If you can, that's helpful. It was a minor comment.
Yeah, no, that's helpful. Rhiannon and then Kay.
Yeah, thanks. And take the point that you made, which made a lot of sense, because for me, this infrastructure is about future-proofing to deliver the strategy, the overarching strategy, but also the clinical strategies. My specific question, and it may be in there, I haven't seen it in any other committees because it's not a committee that I'm on, and maybe it's in the second phase. Would the screening premises be included in this phase? Because I'm aware that can be a real challenge in terms of getting the right environment for different screening programmes, making sure that they also have the quality safety elements as well. So is that in this phase, or is that in a future phase, or it's not?
So it will be in where we know about the proposed schemes already. They will be in the list, as you say, that forms part of the plan, and that as and when we become aware of them, they will be built in. So yeah, it should be in there.
Just in terms of Dorset being responsible for everything, I think it's really important that we're not overlooking the quality of those services. And sort of linked to that, I saw the Path Lab bit, but in terms of other laboratories, because obviously, you know, the capability of those technologies is changing all the time. Sometimes machines might get bigger, sometimes they might get smaller. So just thinking of that sort of future proofing, may not be for this, as I said, this particular one, but for the next phase.
Absolutely. And this will be an iterative process. So as new requirements are identified, they will be fed into the same prioritisation process.
Okay. Yeah, thinking about primary care in the widest possible sense rather than simply GP practices, I was wondering a little bit around the move to use pharmacies more for some of the issues and their difficulties with estates. And I just wondered whether any sort of consideration has been given to working in collaboration with them as well. When you list the sort of what the next steps with regard to, you know, on public estate and all that kind of stuff, because the pharmacies, obviously, if they're going to deliver what they are supposed to ensure a reduction in GP, then we need to know they've got the estate if they're going to work in collaboration with us. Just as a thought, that was all.
Yeah, absolutely. And pharmacy and dental as well are two areas that we know we need to expand the scope of this strategy and make sure it's
not obviously a direct NHS in the same way, but it's still in terms of pharmacies, but it's still something that can be thrown into the pot.
Yeah.
Siobhan? Just to add, it's a really comprehensive piece of work. Writing or developing an estate strategy is quite difficult at the best of times within organisations or across the system. So I do think it's quite a comprehensive document, as you said, Dan, so well done. I suppose there's several things running through my mind about this. One is just the timing of what we're doing. So CDEL and Capital is complex at the best of times, and no way am I an expert, and there won't be any more money, but I am interested to see what a new government is going to do around some of the issues that I think are really highlighted in our strategy. I think that this is a strategy I fully support, and actually my colleagues you support the sort of strategy and as you've written it. I suppose the rub comes in the how, and I think we've got some work to do in the system as to how. And just we may have engaged, and we do engage, but we don't always absolutely listen and address some of the issues that maybe are bubbling up. And I think in the system we need to take account of that and actually not think we've engaged, but you know, you engage, you listen, and then you might have to adapt, change, think about things. And I think we just need to reflect when we're doing documents like this, where it is difficult. How do we take account of some of the differing views in the system and the fact that everyone's trying to do the best, but have very different lenses at looking at risk, at looking at how we create a shift in resource. So overall, sort of a strategy, I think it's really great and I support. I am worried about the bit that goes from section D onwards, that is more about the how. And obviously Matthew and myself will need to take this through our boards, which will be an interesting conversation. And Rob, you're very welcome to attend.
Rob wants to come in now, so Rob, on that point.
So I guess the way I look at this, so I know there's that comment about no new money, no government. Let's be realistic. This is a strategy that puts on the table all the things we need to do, and it's 10 times the amount of money that's available in CDEL, right? So that's your starting point. So CDEL is not the answer to all of this. If we are scraping around in CDEL in the future, trying to put a little bit here and a little bit there, and then we're going to fail anyway, aren't we?
So what do you want to pick on the acronym CDEL?
Sorry, CDEL. So that's the capital expenditure limit. It's the amount of money we get given as an allocation for capital. What's the D? Capital department expenditure limit.
Capital departmental. Yeah.
Yeah. Okay. So it's the amount of money we get given. All I'll say is that we are building new hospitals. We have had hundreds of millions, not from that pot of money. In the past, there was things called, I don't know what the acronym is for, but it was called ETTF, and it was around money that could be used in primary care estate. There has been
ETTF.
Oh, sorry.
Estate Technology and Transformation Fund. Got him. Okay. There was wave 1 capital money for STPs, strategic transformation partnerships, and wave 2 and wave 3 and wave 4. So there are waves of money that come for specific things, and when they come for specific things, they will be spent on specific things, and that will free up some of that our conversation, Siobhan, as we move forward. The problem is we don't know what that looks like, so we're setting that overarching framework and principles around. We will have to get into difficult conversations around prioritising. What that actually ends up with, dialed in terms of numbers, that's the how, that's the difficult bit, Siobhan, that we will no doubt have quite a lot of conversations, negotiations around in agreeing what that looks like.
I took Siobhan's comment as being about kind of understanding that there will be tensions. It's not about the detail, but understanding that there will be tensions, and actually trying to demonstrate, and again, this might be within the cover paper, but how we are engaging and listening to those different rather than the details. So unless I got that wrong, Siobhan, I thought that's what you were saying.
I think that's right, but I think we also need to recognise that as those tensions play out with everyone's problems, and so there'll be points at which in all of our conversations about how we manage the money that some people will win and some people won't, and that's what system working is all about. And so, but we need to understand the impact when we make a decision on all parts. But the money isn't enough to do what everybody wants, and we need to make sure it aligns with the strategic direction that we've got. Otherwise, we're not going to deliver on it.
Okay, so are people willing to approve the infrastructure, the ICS infrastructure strategy even, that we've got here today? Yep. With all of the caveats around, you know, the longer term agenda, the change in environment, etc. But we are where we are now. I've got just one question. So the paper actually said that it was to be published. Rob, when you gave your introduction, you said you didn't know if it was just going to NHS England or being published. I think that's quite significant. So do we need to publish it?
So part of the reason for writing it is we've taken away stuff that we wouldn't want to be in there because it's more about the plan than about all the details, because we need to work through all of that.
Yeah, so we need to submit to NHS England, but we do also need to publish publicly. The timing of exactly when we're supposed to publish for is not being.
Can I make a request? If you need to publish publicly, please can you get some help from Kirsty? It's written in the accessible language standard, because there's no point publishing it if nobody understands.
It's with our comms team to do exactly that, Patricia. Yeah.
Matthew.
Thank you. So I guess I had the opportunity to comment in more detail at the Finance and Performance Committee. I think this is a really strong piece of work, and I absolutely endorse the direction of travel, and I think the commitment to primary care and recognising that is very important. Just in terms of picking up on the discussion that we've had today, of course, working in this way is more challenging, and there is much more opportunity. The traditional way in which the NHS has worked, which is to compartmentalise the capital allocation by organisation, and often not to include primary care. So I think we need to understand and think about the challenges and the opportunities. And so a couple of them are these, which is one is just in the adoption of this. So, picking up on Siobhan's point, this hasn't yet been through the two boards of the organisation that I represent here. But I think this is the ICS strategy, and so I think it's the role of this board to approve it, and I suppose it doesn't sequentially need to go through each board, would be my view of the governance, in the way that, for example, our system financial plan is. But the strategic discussion with each board, of course, is very important, and we've got it on the agenda for our appropriate subcommittees, etc. And then the second thing is, in terms of how we make the decisions going forwards, how we address conflict, how we really understand what we're doing, and hear those voices across the system so that we recognise the impact of our decision making. That's going to be really important. One thing I think we could do to support that is ask the teams to just draw out very simply, and I know some of this is in here, but how the governance will work. So what is it that we're going to see in the system architecture, and where there's conflict, how do we expect those things to be serviced so we can have the right decisions, make the right decisions together?
Yeah, and be consistent in the way that everybody's assessing risks, so we're actually doing the right comparison.
Okay, right. Well, thank you very much for that, Mike, and not just for the paper that you've got lots of, but being able to respond to all of the questions that you've got as well. So thank you very much for that. We're going to move on to dental access and oral health, and Kate. Oh, sorry, forgot about that. So we're moving on to freedom to speak up, which is, we've got James. Is that James on?
James is for Families First for Children Pathfinder.
Thanks, Matt.
Okay, I'll catch up in a minute. My agenda is slightly different. But Dawn, over to you.
Thank you. Thank you, Jenny. So this is the Freedom to Speak Up, the Raising Concerns, the annual update for NHS Dorset Freedom to Speak Up. So I'm going to take the paper as read and just pull out a couple of key points. And the first is, to be clear, this is a review of NHS Dorset's Freedom to Speak Up activity. The ICB isn't required to assure itself of the wider provider freedom to speak up data and action. However, cultures of psychological safety are part of our ICS people plan, and that work in its broadest sense is overseen by our people and culture steering group and the Freedom to Speak Up and staff networks across the system. So the context for this paper, I'd ask the board to note and consider that this report is in a period of quite large organisation change and disruption for our staff. So on two counts. One is the continuing shift of what it means to be an ICB, an integrated care board, as opposed to a clinical commissioning group, and the change in the expectations of our people and the roles that they take, and then also the context of the running cost allowance reduction that's been taking place. So in any challenging and change, the need for psychological safety and speaking up, and the ability for people to speak up, is even more important. So I very much welcome the concerns that have been raised and the number of concerns that are coming through. What the paper doesn't include, and the board might note, is that our freedom to speak up data is not cut here by protected characteristics, and there's a reason for that, and it's because of the size of our organisation. It's less than 500 people. When we start to drill down into the data, it becomes we're able to identify individuals, and so that's not the place for this report. However, that said, then triangulating this data with our staff survey and our what we know is that people who are part of minority communities, people with protected characteristics, have a worse staff experience and find it more difficult to speak up. So that focus and attention is part of our ongoing culture work. You won't necessarily see that reflected in the data that's in this report. And then happy to take further questions.
Thank you very much, Dawn. So questions, comments, observations? John?
Thank you very much, Jenny. So I take the role as the Freedom to Speak Up champion on the board as well. And I just really wanted to say how much and how critical I think it is that we live this every day as board members, but also take a leading role. Whilst this is an annual report, I'd really point us towards the plans in section 6. They speak crucially to culture and about how we're promoting that. And I think as a board, it's essential that we're playing our role in that culture. But this message that I also wanted to reinforce about speak up is effective when we then listen up and follow up. And I think one of the things I'd really point towards is the intentional action that is taking place that is covered in section 6. And we need to do that in the context of lots of platforms, and those platforms will be developed. So I just wanted to really put behind an endorsement of this work. I meet with the team on a regular basis, and they work really hard to make sure we're discharging the obligations, but this needs to be right at the fore of how we operate in NHS Dorset.
Thank you. Anybody else? Okay, so it's here for noting and discussion. So thank you very much, Dawn. And I think everybody will endorse the comments that you've just made there, John, particularly around the listening up and following up, because there's not much point letting people speak up unless that happens after it, is there? So very much for that.
Yeah, and thanks for all the leadership on this, Dawn, and to the team as well, who work really hard for all of us in NHS Dorset.
Right, so now I'm back on with the correct agenda. Let's move on to Families First, the Children Pathfinder update. And James.
Yeah, thanks. I'm here with Jill as well from Dorset Healthcare. I'm going to share my screen. Just give me one moment. Can everybody see that okay?
Yes, we can.
Great. So yeah, the purpose of this presentation is twofold. One is to give an update on the Pathfinder generally and how things are going, but also to have a focus on Dorset Healthcare's involvement with the Pathfinder, and Jill, who's been seconded onto the programme for the last 8 or 9 months, focus on some specific bits that we're doing within the programme. We presented a couple of times to this board over the past year, once about this time last year when we were first gearing up to co-design and implement the reforms, and then at the back end of last year as well. So hopefully people are familiar with the programme, but just very briefly, background to the Pathfinder was the independent review of children's social care and the government published Stable Homes Built on Love that was published in February 2023. And one part of that strategy called for some Pathfinders, Family First for Children Pathfinder. We are one of 3 areas in Wave 1. There's now 7 other local authority areas across the country delivering and plans for Wave 3 as well. And I suppose I should say that this strategy had good cross-party support nationally, so we don't expect there to be too much change, although you never know with a new government being in place now. Ultimately, we're continuing to forge ahead with the reforms. Very briefly, there are 4 pillars to the programme. So family help, which is about bringing together what we currently call early help and child in need work into a single offer. Wide-ranging reforms across child protection, across both family help and child protection. It's really about deeper integration between partners. Family networks, which is a golden thread that runs through all of the strategy. That's about embedding family group decision making within all the work that we do, and then some very specific things around the safeguarding partnership, not least the role of education and potentially bringing education on board as the 4th statutory safeguarding partner. This is the way that we've been trying to describe the programme. We've been inducting our locality staff into the new model, and there are plans for partnership inductions, but really what we currently call early support, so community-based preventative support through family hubs, voluntary community sector services, early help, which is targeted early help that's currently delivered by our multi-agency locality teams, and child in need work, really that all comes together into what we now call family help. And this is in the pack for people. We've tried to bring this to life with a 2-year-old example and how that might look for a 2-year-old who's moving through the system, recognizing that you wouldn't want needs to be escalating, but it's just to demonstrate the example. That's what this program is about. In terms of the specifics of how we're implementing the reforms, and again, there's information in the pack on this, the 2 bits that I point to, and Jill's going to say more about this, are the second box here, which is about our single conversation-based front door, which is going to bring together expertise from social work, family help, education advice, special educational needs and disabilities. And we're hopeful for CAMS, recognising there's an ongoing CAMS transformation that sits alongside this. And then the third box within family help, which is about family help lead practitioners holding the relationship with the family, and that could be anybody from the multidisciplinary family help system. So it could be a health visitor, for example, less likely to be somebody from police, but possible, I suppose. But that's another one to point to in the context of health and the partnership. And then within child protection, we've had an updated child protection conference process that's being piloted in Dorchester and West for the last few months, and Jill's been working closely in that space and is going to talk to you a little bit about what that looks like. But those are the main ones that I would point to. There's lots going on, but main ones I'd point to in terms of how the interface between the Pathfinder and the local health system. Again, lots of information in this, but we've done a huge amount of work and there's a lot that's live now. So we've spent a year gearing up and implementing things, but within each of the pillars there is lots that live. So family networks, we've got a local kinship care strategy. We've now got an internal family group conference service within the council, which is new. We've got practice guidance for all of our practitioners, not only within the council, but also looking across the partnership about how we intend to embed that principle of family networks across the system. Family help, again, we've got family help at that integrated front door. Our Dorset Education Advice line is now integrated in the front door. We've come up with local career pathways for family help. There's work to do probably nationally on that, but we've defined our local career pathways for that. And again, practice guidance has been drafted across all of this. Jill's going to talk a little bit about the child protection conferencing pilot, which is live as well, and we also have a multi-agency child protection operational board that's meeting monthly that has representation from health, police and other partners as well. I'm racing through this because I want to get to Jill as soon as possible, but in terms of a timetable for implementation, we're now in July, so we're looking at these locality multi-agency child protection teams at the moment, and our local multi-agency line of sight meetings are now live, and then lots to happen over the next sort of 3 months or so. So we're intending to have family network support packages delivered through the voluntary community sector, full rollout of the updated child protection conferencing pilot to the entirety of Dorset at some point later in the year. Probably won't be August, more likely September, October now, and then lots more to come as well. And alongside that, we're making wholesale updates and changes to our case management systems, which for Dorset Council is Children's Services Mosaic. That was very quick, so hopefully it was helpful, and there is more information in the pack if people want to read, but I'm going to hand over to Jill to give us an update specifically on Dorset Healthcare's involvement in the programme.
Lovely, thanks very much, James. Hi everybody, so I'm Jill Warren. I'm the lead for children, young people and families in Dorset Healthcare in my day job. So I've been seconded onto Pathfinder, as James said, since October last year. Right at the beginning of the project, we were seconded in with police colleagues as well. So we're very much a multi-agency project team, helping to design the programme, how we take it forward and how we implement it, embed it within practice. So I just wanted to show you very briefly the model that we've developed within Dorset. So we're very much a provider-led model. So Dorset Healthcare are leading on it, but we're pulling in support from PCNs, voluntary sectors and acute trusts as well. And how do we link up all the services that we provide across health? When I'm talking about health, I'm talking about NHS services. So because I appreciate that health comes from a variety of places. So it's just how do we have the oversight and enablers if we're coming across hurdles or barriers within the programme, who is it that we escalate to? Can I have the next slide, James, please? So I just wanted to talk really briefly about the health governance arrangements, just for your awareness, really, more than anything. So it's very much a test and learn. We're working new ways of working. We're testing them out, reviewing them, redesigning them, and then testing them again. But part of that is around the governance structure that we need to have in place to make sure that we don't lose any of the quality from the health services and the safety of the health services that we provide. So we've got the 4 work streams, which are all multi-agency. We've got police colleagues in there, we've got health, and we've got local authority. All the findings that come out of those work streams then feed into the Pathfinder Operational Board. We've also set up a health panel as well, which goes across NHS Dorset. We've got people from County Hospital as well, safeguarding GPs who sit on this health panel as well, to give us some scrutiny and that quality assurance around the health element of the programme. That then feeds into the Pathfinder Programme Board, and that's overseen by Department for Education and NHS England. So we're using the principles of PDSA cycles. So we'll plan it, we'll do it, we'll study it, we'll act it. And then if we need to, we'll review it and then repeat the cycle again. Next slide. So what does this mean for Pathfinder? What does it mean for NHS services? So we've got teams, multi-agency teams working on all the 4 pillars. But the 2 that I really wanted to sort of focus on, if you can put all 4 of them up, James, that would be great. So the 2 that I really wanted to focus on was around the integrated front door, which James alluded to earlier about us sitting all together. So when a referral comes into the CHAD, which is the Children's Advice and Duty line, that traditionally pre-Pathfinder was supported by the local authority, and they would have consultant social workers that would sit in that team. We've put some health professionals into that. We've put school nurses in there, and also practitioners from CAMS Gateway. And what we've found is that when a referral comes in now, and you can have that multi-agency discussion at the point of referral, it does change outcomes for children and families. It was very evident right from day one when we were all sat together that we were managing to get better outcomes and putting services in place for families that traditionally they would have had to navigate the health system themselves. But what we've done is bring it in-house, looked at it together, and we've done the navigating for the families and the children themselves. So it's actually meant that we've doing a bit of protection around some of the specialist services that we provide, like CAMS or speech and language, but we've said actually it'd be more appropriate for this young person to be in this service instead. So we've been able to look at all the services being provided and put them into the right place. The second bit is around child protection. Traditionally, we used to put families through the child protection process, and we would do things to families. We'd tell them what they'd done wrong, and we'd say, this is the plan you need to work to. With Pathfinder, we've flipped that on its head and said, how do we support families through this process? How do we work with them to achieve a plan that is actually realistic, and it's one that they can actually achieve, and we can give them the time then to change how they're working as a family, and how do we support them? And really it's much more about what services can we offer the family, rather than them having to navigate the system and us saying you have to go and access this service or that one. We will help them do that. We'll support them into it, because really what we're trying to achieve is that children don't sit on child protection plans as long as they are at the moment, and ultimately children don't come into care. So really we're just trying to support families in a much better way to help them access services rather than leaving it to them to do. So another part of the role that I'm in, this is the exciting bit where I'm right in the middle of that centre where all the different services that have been provided. As we know, IT systems across health don't all talk to each other. So my role, as we've gone into the programme, I've realised actually my role sits right in the middle and looking at different services and saying, how can we link them all up together? How can we streamline some of the services that we provide? And I think a good example of that was last week I met with the Safeguarding Families Together team, and they were telling me that they've got problems recruiting into the mental health practitioner role. And they were saying, we're going to have to do something different because we just can't fill that gap. And I said, well, have you spoken to the children and care team? Because they've got a new model, but it's not a new model, it's a different model for the emotional health and wellbeing practitioners who we've trained up into those roles. So I've connected those 2 teams together to think slightly differently and try to bring a bit more creative thinking, because as we know, resources is tight, but how do we look at the things that we're already providing and try and do something a bit more innovative? So that's part of my role, is doing that, navigating different services and trying to link them all together. So today, collaboration, the whole point of Pathfinder is that we're working very much as a multi-agency team. We're all collaborating together, but we need the whole system to collaborate. So it was really just to say about the commitment to the programme changes. How do we make them sustainable going forward? Because once Pathfinder finishes and we've embedded all the new practice, how do we make that sustainable? But also it's about reducing barriers within health, you know, around systems, around thresholds and criterias. How do we look at the needs of families and children and think slightly differently about how we access services and looking at their need rather than saying, well, this service will only accept you if you meet this criteria. So it's about reducing barriers across the whole health system. Also looking at resource opportunities. It's just around commissioning arrangements that we have. Can we do things slightly differently around roles that sit within specific services, you know, because it could be that from the commissioning from one service actually would really benefit another service, but it's looking about, you know, doing something again a bit more creative about the resource that we've got. And then also really to ask you all, you know, about meetings that you go to, looking at the wider system communication, tell people about Pathfinder. We're doing something really exciting here, and I think we can really influence national policy and national change. But we need people to be able to go out and champion it for us as well across the wider system. And then just the last slide, please. So the enablers that we have at the moment is we've got a national steer from NHS England. We've set up our ICB health panel. So if anybody else would like to come and join us on that panel, you'd be very welcome. Also looking at data, we're all the agencies, police, health and the local authority, all looking at data collectively to analyse it properly to then shape services coming out of Pathfinder, which has been really exciting to be able to do. And then also looking at resource to gap specific roles. So we know that we've got gaps in parts of Pathfinder, but it's how do we collectively look at that and say, how do we plug that gap and where's that money going to come from and where's that role going to come from? So it's a really exciting time. So that's the end of my slides. I've rattled through that really quickly, I'm afraid, but I'd really welcome any questions that anybody might have about Pathfinder.
So can I thank you, Jill and James, for both rattling through, because that helps us to stay on time, but also actually for conveying the your real interest and excitement around this programme. So let's go for questions and comments. Kay, then Rhiannon.
Thank you very much. This was really interesting. My background was in education, so I found this really exciting when I was going, because I know from all my experience in that one of the key issues with regard to child protection is the failures in communications across the various services that are working together. I just wondered how much you were involving education, especially early years education in this one, because there's a mention of it every now and then it's not in the enabler section, and yet you would think that the early years teams in primary schools and in many of the nurseries would be absolutely crucial in this one.
James, do you want me to step into this one?
Yeah, you go ahead, Jill.
Yeah, so the early years, we're working very closely with early years and SENCOs as well to make sure that...
I'm going to take a few questions.
Oh, sorry, yep.
So that we can keep on time. So I've got Rhiannon, Matt and then Debbie, and then if you and James come in after that.
Okay, yeah.
Thanks, Jill and James. So it's a bit continuing on a theme that you've just heard. So we understand, don't we, in terms of some of the recommendations that come out of reviews. I wanted to understand whether the pathway has really leaned into those, I guess, and has tried to incorporate those into the design and ensuring that any recommendations that have come before from those kinds of, I'm talking about safeguarding type reviews in that context. Just building on the point around communication is always one mentioned, isn't it? So we've heard in your presentation some of the improvements around that through this model, which is great. But the other bit for me is the digital interoperability. And clearly that's a bit more challenging. That's more than just the data. So just wondering where we are on that journey. And just one more thing for me, because one of the things that comes out repeatedly is the voice of the child. And although I absolutely heard about you working in partnership, I didn't hear anything about the actual voice of the child. And my background's in health and I've spent time in safeguarding. So just so you've got some context for where I'm coming from. Thanks.
Thank you, Matt.
You won't be surprised that I'm really passionate about this and incredibly supportive of what's going on through here. I'm really proud that Dorset was one of those first pathfinders. You know, at the heart of it, the details that will questions that you're asking are really important, but this is about making a difference to our children. That early intervention and prevention piece really important, and it's a pilot, and it's been funded as such. And so one of the risks to the programme potentially is that we're now in a new period of new government. Is that funding going to continue into that? These things need time to bed in, don't they, and take real effect and make a real difference. But we all know that prevention is better than cure. We all know that actually if we invest in this up front, we will see improvements in our outcomes and the pipeline to the cost. But until then, it's about improvement to our children's lives. And that comes back to the heart of the conversation we had earlier around social mobility, aspiration, education attainment, general wealth, levels of health. It's all connected into this. So it's a really wide project. So my plea would be, if you've got influence, particularly anybody connected to the new government around that thing, is around making sure that this pilot continues and is properly funded as we go through that process.
Thank you. And Debbie.
Yeah, just a few things from me. As you know, I'm fully engaged in this and really, I'm on the board and have seen it developing, so really supportive of it. I mean, there's a few things for me. The first thing is just a question for Jill. Are UHD included in your health panel? Was one question. I think we had this discussion at the Dorset Safeguarding Children Partnership last week as we were solving that and moving into place-based arrangements. An acknowledgement from Dorset Council that actually need to make sure that UHD are engaged just because it's on the Dorset side. So that was my first question. If not, they probably should be around the table, I think. The second thing is obviously it's great that your post has been seconded and you're doing a fantastic job, and I've seen how much you've done over the sort of 9 months or whatever it's been running. But the issue in the room that Matt sort of slightly alluded to is the fact that, so there is no health or police funding for this, and we're doing it, and I think that's a real missed opportunity. And I know Teresa is continuously escalating that nationally, and it's somewhat frustrating, I think, that the whole Pathfinder approach is all about working together in partnership for the benefit of our children and young people, and yet the project is funded through local authority and health and police and education, I guess, as well, haven't got any separate funding. So I think if we're going to push for ongoing funding for the pilot, we need to push for it to be funded properly so that we can actually really give it our all, because otherwise you can't do dual running. You always have to try and tweak the resource you've currently got. You can't. It's supposed to be a pilot. You're supposed to be able to test it, aren't you? And we find ourselves from a health perspective always having to, well, how can we move people? How can we tweak it slightly rather than doing it really effective? I think we're still doing well, but I think that then brought me on to Jill from a Dorset Health healthcare perspective. How are you learning from the pilot on the Dorset side to then try and inform what you might be doing across the whole of Dorset? Because obviously one of my biggest concerns is that it's amazing what's happening on the Dorset Council side with being part of Pathfinder. The quicker we can actually move some of that improvement and new way of working to benefit all of our children across Dorset, the better, really. So I guess Dorset Healthcare is actually in best place to actually do that, because you offer a service right across, and yet you're learning from the pilot. So sorry, that's a lot of questions, but
no, go for it. So Jill and James.
Okay, so I start, James. So if we go back to the early years work that we're doing, we're very much working with early years providers and Senkos as well. We've got a format that's set up for children that maybe have had ASQs that have been identified as having a need but haven't quite managed to access any services. These are children that are going to be going into school, and we can't wait for children to go into school before they then have that need identified again. So it's about sitting together as a multi-agency team, identifying, who is it that we need to be providing a service for. So it's very much around that early years support and putting support in much earlier before the children even hit school. So it's really looking at what kind of services can we provide and trying to turn it around to be very supportive in the early years. So that's a real focus for us. I think around the safeguarding thing, like you say, around the voice of the child, we have evaluations, and we very much have children's voices within the evaluations, the formal evaluations that we do. Also around the services that we provide, 0 to 19, speech and language, all the different services, children in care, we get regular feedback about how things are happening within the services and how do they shape the services that we want. And we bring that into Pathfinder and say, well, this is what children have actually told us. You know, lots of children have said around mental health support, you know, that's really shaped how we've gone forward with mental health in schools teams. You know, who is it that they want to work with? Who do children want to work with, rather than what do we think as professionals they need to work with? So I think it is very much the voice of children is right at the heart of Pathfinder, and we've got all the evidence behind it. What have children said about processes? We've even spoken to them about attendance at child protection conferences. Do you want to come to the child protection conference, or do you want to, you know, is it appropriate for them to come? Hearing their voice within that, and with the QAROs and the social workers that we work with are very keen to have children's voices in everything. And I remember Teresa saying that actually it's the children and the families that direct us. You know, we are very much led by what's been fed back from children and families. And we've got Chris Scrivener, I think he does a lot of parent engagement work, and he produces a report very regularly for Pathfinder. What is it that families have said about this, and have they seen a difference so far with the pilots that we've been doing?
Sorry,
I was going to say about the digital offer as well. We do have digital work that's coming through the family hubs. So we have a work stream through the digital work stream that comes through family hubs. So that's a universal offer that all families will have, that then feeds into this Pathfinder system if there's an additional need that's been met. But there is a digital work stream, isn't there, James, through family hubs?
Yeah, there is. And the only other thing that I would add to all of that is sort of remembering the sort of inception of this program and why Dorset was selected as well, because it's not easy to lose sight of, but ultimately the first 3 wave 1 sites were chosen because of the pre-existing conditions of success locally. So, you know, Dorset, Lincolnshire and Wolverhampton were all seen as being really sort of strong local systems. So the point around you know, child and family engagement, absolutely right, and it is at the heart of the programme, but it was already there in many cases as well. So we're building on these really strong foundations. Yeah, it's a really exciting programme. We can share huge amounts of information with you. Over the last year we've done a lot of work. So
thank you both very much. You were breaking up just slightly there, James, at the end. I think Matt's point around the influence to keep this programme going and have it funded properly so that we can really do a pilot is actually, for me, the key takeaway that we need to take from this. So asking through the teams to let's keep doing what we can to try and do that. I think we're all part of different networks, so let's try and see how we can coordinate around that to get this kept on the agenda. Thank you very much.
Thank you.
Cool. See you.
So bye-bye, have a good day. We don't have any questions from the public, so nothing to cover there. Any other business? I'll just go around the table, starting with Matthew. Rhiannon? Sorry. No, okay. Can you show any other business? No. So key messages. Liz?
So I took the key messages as that we welcome the board story on the provision for our African migrant and asylum residents, especially noting positive community response and the multidisciplinary working. We iterated our commitment to prevention and health inequalities and welcome that this appears to be in alignment with the government strategy. We welcome positive delivery around quality, finance and operational performance, but also recognise challenges around known criteria to design and dementia diagnosis. We approved the terms of reference and the delegation agreement to the Ambulance Partnership Board and also the Dorset ICB strategy. In relation to freedom to speak up, the board noted its role in promoting speaking up in tandem with listening and following up. We also supported the Pathfinder programme, support the ongoing funding and the expansion of this funding to wider partners, and welcome the collaborative work which is being demonstrated in that area.
Yeah, can we add to that the whole thing around engagement and influence, and because I think that's the key thing that we probably need to do in relation to that. Review of the meeting. Any questions? Any observations around the meeting?
It's just one from me, which is 10 o'clock till 4 o'clock with 2 10-minute breaks and half an hour for lunch, is it enough? Because we'll lose people not concentrating because they're tired. And I looked at the agenda this morning and I thought, oh my God, half an hour for lunch. It's just not enough to stretch your legs and refocus your mind.
Yeah, I mean, we'll have to think about how we do it differently, won't we? Because even with losing one of the papers, we're going back against it. So yeah, let's look at that. I think it starts with you and I to think what we can do with that. Any other comments on the meeting?
There's some good, healthy discussion today.
Lisa?
I think you mentioned it, but it's worth pulling out is that the front sheets need to work harder to give us some context, and that means that we can save time and stay relevant in the discussions. So
Yeah, no, thank you. I was just about to raise that and one other thing actually. So I think as much as we can, if we can use that cover sheet to steer the discussion and the thinking beforehand, I think it will lead to a real fulfilling meeting in terms of what we get out of it. Second thing for me, it was really heavy this month with papers. The open session alone was almost 400 pages, just 6 pages short of 400. That's a lot of reading. It's really hard to get into to know where you direct your questions and even what we're being asked to do. So I don't know if we can do some work. I remember the first meeting, Patricia.
I think
6 pages.
Well, we had 600 in the first meeting.
We did, but your aim was to get to 6 pages per
I
item.
think that if I'm going to provide all the updates from partners, I can't get to 6 pages. But what I do think is the reports that can get to 6 pages, Liz needs to have the right to veto them if they can, because we need to get better at writing concisely. Otherwise, people can't ask sensible questions because there's too much detail in the papers. And that's why the front sheet needs to be a really good summary of the main points in the paper and what are we asking the board to do.
And keep it strategic, not operational.
I would absolutely agree with that. There might be something about having the papers, and then if there's a sort of set of reference documents that people want to provide, but
Which is what I'm used to. Yeah. So anyway, thank you. I mean, I know a lot of work went into all of that, so it's not at all to undermine that, but I think we just need to keep the board focused where it is. And I think the papers and how they're presented can help with that. We are running almost 5 minutes behind, taking on board what Patricia just said about time. I will still let you have half an hour. I'm back at 2:05 on the dot. That will be helpful. That ends the meeting in public. Thank you for those that came and listened. And see everybody else at 2:05.